Good morning, ladies and gentlemen. So I'm Dr. Lin Yanzhang, the Director of the Cardiology, Taipei VGH General Hospital. Welcome to the Taiwan ROVUS Live. So first of all, I'd like to express our sincere appreciation to the international and domestic faculty to join the stream conference. I really appreciate the course chairman, Dr. Lu Zemin, and also appreciate the specialist John Bonet to join our conference. So I like to highlight the symposium of the meeting. This is the image technique of non-invasive for interventional cardiology as the IVAS, and also the rotational arteriotomy. I think this is quite important as a non-invasive coronary artery intervention, and also the intervention technology. So I'd like to express our sincere gratitude to also participants to join the meeting. Thank you very much. I hope this meeting will be successful. So I'll give my chair to the course director, Dr. Lu Zemin, to head on this session. Thank you.
Thanks, Professor Lin, for the opening. And it's my honor to moderate this section. And the first section, we are happy to have Dr. Hongye from the Japan Kakura Memorial Hospital. And we know that Hongye is very, very famous IVAS expert, and not only in Japan, in Taiwan actually, many experts are familiar to her, and we are very, very happy. And I'm sure that we will learn many IVAS knowledge from her. And we have another two co-chairmen, and from my right hand side is Dr. Cai Zhenting from the Taipei Memorial Hospital, and they also famous expert for the complex PCI and the CTO. And for my left hand side is Dr. Zhang Qiren. He is from the Taipei Linkou Trunk Memorial Hospital, and he's a chief and also expert for the complex PCI and the CTO. And so in this morning first section, we will arrange two cases, and one is bifurcation case. The operator is Dr. Huang Shaosong. And this case is lemma bifurcation and with some calcification. And we have another case is the CTO, complex CTO of the RCA. And the operator is Deng Xinyi. So can we go to the classroom 1? Good morning, and now you are on air, and Dr. Professor Lin Yanzhang, Professor Cai Zhenting, and Professor Zhang Qiren all together. And can you introduce your case?
Okay, before we show today's first case, I will introduce my team member. My first assistant is Dr. Lu Yawen, and the second assistant is Dr. Wang Yi. And Dr. Lu will introduce today's first case. Can you show the slide?
This is 60 years old male, and he presented with chest tightness for several months. He has several medical history, including coronary artery disease, and he had performed a fellowship in 2016. And he also had type 2 diabetes, hypertension, and dyslipidemia, all under medication control. So he had several risk factors, including his age, hypertension, diabetes, and dyslipidemia, and smoking. So next page. This is the coronary angiography performed in April 12th. And you can see he had conducted the CABG in the before. And the RCA was the chronic total occlusion. So next page. And this is the left coronary angiography, which revealed LAD diffuse lesion from proximal to distal with heavy calcification, and the circumflex also had about 80 to 90% stenosis at the distal part. So next. So the lima was atrophy. So, and the graft of the GSB sequential to the diagonal, and OM branch was patterned. So next. So today we have to treat the lemma bifurcation lesion, and this was the Medina 010 lesion, and the syntax score was 46, and syntax 2 score was 49.6. Thank you.
Okay, it looks like the target lesion is the lemma bifurcation and the LAD diffuse long lesion. So maybe Dr. Huang Shaozhong, can you introduce your strategy?
Okay, because his right coronary artery is occluded and hypoplasia, the circumflex is dominant. So we can see the distal circumflex, maybe the marginal branch is maybe 80 to 90% stenosis. I think this territory is also important for him. So we will first treat the circumflex distal lesion, maybe the marginal branch lesion first. And I will use IVAS to check the heavy calcified lesion from LAD ostium to distal, and the ostium of circumflex. And we can, maybe we will show, maybe we can know we will use 2-stent strategy or 1-stent strategy crossover from left main to LAD.
Yes, Dr. Huang, can we see the caudal view? Okay. Yeah, I think this is a very long diffuse LAD lesion, and with some calcification and some tortuosity. And but circumflex looks like it's relative disease-free. So regarding the strategy, I would like to ask a comment of our commentator, Dr. Zhang Qiren.
As Dr. Lu mentioned, I think the major problem is the LAD quite diffuse and angulated lesion with some calcification. Luckily, it seemed that at least at the osseo circumflex, angiographically, it looks relatively disease-free. Maybe we have some disease at the distal circumflex, but maybe we can skip the 2-stent for left main bifurcation. So I think the major problem would be the LAD. So can we see the RAO cranial?
RAO cranial.
Yeah, it seems that the calcium is not that heavy. So if we can avoid road ablation, maybe it's good because it's quite angulated. But anyway, I think we need IVAS to make final decision.
Yes, I agree. IVAS may be very important. So, Dr. Chan.
From the angiogram, this caudal view, I agree with Dr. Zhang. The target lesion is LAD diffuse calcified lesion. After IVAS, check the IVAS, can decide the strategy. But I think from the angel, maybe in the lemon lesion, I think it's just single course of technique, one stand strategy is okay. I think, but by the IVUS guide. But before the standing, I think the distal circumference is quite long diffuse lesion. So before the lemon standing, I think I will treat the distal circumference lesion because the RCA is relative hypoplasia and the circumference dominant. So this circumference territory is very big to supply the posterior lateral wall. Okay.
Yeah, yes. I think that was mandatory in this case, but you know, some experts were address the importance of the angiogram for the detection of the circumferential calcification. Like Dr. Li Wenli, and they was very emphasize that inspection of the angiogram from many views and see the calcium distribution above and below, and maybe indicate that circular calcium distribution. Maybe rotor abrasion is needed. So I would like to ask Dr. Hong Ye, do you think that the front angiogram, the rotor abrasion is needed before we check the IVUS?
Oh, okay. Thank you. I agree with other commentators. And when you look at the angiogram, and in proximal LAD, you can see some calcium, like a sandwich-like calcium. And I hope that this calcium locates quite deeply inside of the plaque. Then you cannot, you will not, the rotablator is not necessary in that case. So just proximal LAD, yeah, hopefully we are able to use a cutting balloon or so, but of course depends on the IVUS findings. Thank you.
Yes, because I think there are some potential risk for the rotation, for the perforation. Is some tortuosity we can see. So, Dr. Huang, do you have do the IVUS?
Yes, yes.
Can we see the IVUS result?
Okay, we can show the IVUS, but from the IVUS from LAD, we cannot advance the IVUS to distal LAD, so we can only advance the IVUS caster to middle LAD, so we can see, we will show the IVUS image from middle LAD to LAD Austin. Dr. Huang will show the IVUS.
We have an expert, IVUS expert, Dr. Huang Weijie, to do the preliminary IVUS interpretation.
Okay.
Dr. Huang, please.
Okay, good morning, Professor Lu and Dr. Hong. The patient have the long LAD long diffuse lesion, and we prepare the IVUS from the LAD middle to the lemon. Let me see the IVUS result, the finding. We see the distal, the middle LAD, the diameter around the 2.0, and we see the classification below the concentrate classification, but we prepare from the middle to the proximal. We can see the lemon. We can see the lemon diameter about 4.0 diameter. So we suggest maybe just like Dr. Hong, we can use the cutting balloon from for this lesion.
Yeah, can we see the IVUS again? Yes, it looks like it's more than 180 degrees calcium distribution and eccentric calcification. So, because you mean that first the IVUS casket cannot push to the distal LAD, right?
Yes, yes.
Dr. Huang?
Yes, we can show the...
Yes, the IVUS casket cannot pass the LAD middle.
They cannot pass, only advance to middle LAD. could not be advanced to distal LED. We can see the angiography.
Yes, from the IVUS, I think that's the eccentric calcification, but the lumen is maybe near 2 millimeters. So I think is because you know that the uncrossable image catheter cannot pass is also an indication for the rotor operator. So what do you think, Dr. Zhang? Is rotor needed or just we can do the cutting?
I think so far what we can see is the more proximal segment, which is quite safe for rotor ablation without acute angulation. And we do have concentric calcification at proximal part. But the problem is the mid and distal part, which segment with a very acute angulation. So, of course, in clinical practice, if IVUS is uncrossable, we can consider rotor ablation. But it seems that for the more distal segment, there's it's not so heavily calcified to me. I'm not sure. So I think maybe we can still try cutting balloon for proximal part, and if cutting balloon cannot cross the mid section, we can try a high pressure balloon first. As we know, the prepared care trial, which has been reported maybe 3 years ago, if the lesion could be dilated with either high pressure, scoring balloon or cutting balloon, then we can skip rotor ablation and we can achieve the same long-term clinical outcome compared with rotor ablation. Of course, there's maybe 1/5 of the patient which cannot be fully dilated with a cutting or a scoring balloon. For those patients, maybe we need rotor ablation for lesion preparation. So I think for this we can still try cutting balloon first.
How about Dr. Chen?
Mid portion behind the vena portion is relatively eccentric calcified, and from the IVUS, maybe the calcium thickness is relative more than maybe 500 micrometer. So I just concerned the cutting balloon or scoring balloon cannot cross the thick calcified lesion. So maybe NSE alpha can cross maybe. If NSE alpha can cross, maybe it's just scoring and standing. I just concern cutting balloon cannot cross. Maybe small bird rotor ablation and followed by nominal cutting balloon and standing. Maybe can try this kind of strategy. Okay.
Actually, I think that the new generation Wolverine cutting balloon is the profile is very, very small. I think that maybe possible it can cross, but actually from the clear view, the calcification looks not so severe. But from the caudal view, you can see that there are minimal calcium distributed around both sides of the vessel from the caudal view. So there's some angulation of the LED middle. So I think maybe later we will need the rotor operator for that part of the LED. My personal, I think that the rotor is needed, but because you know that there are some eccentric calcification distributed in the middle LED, and if we use cutting balloon, there is a potential risk for the bread in the normal part of the vessel. I think may carry some risk of perforation. But I would like to ask Dr. Hongye's comment for this case from the IVUS view. Yes.
Okay, thank you. Actually, Definitely the IVUS could not pass the lesion at the mid-LAD, and at least if you see the angiogram at the curvature, there are thick calcium inside or inner curvature. So I would like to recommend to use 1.5 burr just right at there from the tip of the IVUS catheter to cross the angulated site. And if you look at the IVUS in proximal LAD, there is quite a large amount of soft tissue, so you should avoid debulking or ablating that proximal LAD.
Yes. Can we see the IVUS again? So
IVUS.
Dr. Hongye, from the IVUS, what do you think about the wide bias of this case? Because some angulation, yes.
Okay, so so right here, the IVUS is facing to the pretty healthy segment, so I don't want to ablate this segment. But probably the tip of the IVUS catheter is more distal to this area.
Yes.
So if you put a platform distally or the tip of around the tip of the IVUS catheter, then it should be okay. Because in angiogram, the calcium locates at the inner curvature of the of LAD, so that pretty nice guide wire bias could be expected.
Yes.
And around here, it should be okay.
Yes, yes.
But coming back proximally, there is a large amount of soft tissue around here from 6 to 12 o'clock, so that we should avoid ablate here.
So you mean that we should park our bird in the relative proximal to middle part of LAD and do the roll time? Yes.
Right.
Okay, this is a very important viewpoint for the how do we do the rotor safely to avoid rotor unnecessary part and observe the very carefully for the wire bias. So what do you think, Dr. Zhang? Do you agree you use the rotor first and check the IVUS, the strategy suggested by Hongye?
Yeah, I think, of course, rotor is a good option, although I think maybe we can also try cutting. To be honest, I think in Taiwan for daily routine practice, a lot of sites maybe in concern of the cost, the rotor operation is not the first option, but usually in live demonstration, we go different strategy. We always choose a rotor operation if needed. Of course, I think for this case, rotor is fine, and I agree with Dr. Hongye's recommendation. Maybe the 1.5 is a good option for to start rotor ablation.
So, Dr. Hongye, do you prefer the floppy rotor wire or extra support for rotor wire for this case to increase the wire bias?
Usually in our practice, we start with floppy wire. However, in this particular case, I would like to recommend to use support wire because we want to ablate inner curvature at the angulated site.
Yes, this is also very important. But we know that the extra support wire increase the wire bias, but also increase the risk of the perforation.
So I intentionally I want to ablate the calcium at the inner side.
Yes, but you know that we do the IVUS from the maybe I did not know that the wire is cyan blue, right?
Yes.
Cyan blue.
Yes, cyan blue.
We always use the Warhorse wire to do the IVUS first. So the wire bias may be different from the floppy rotor wire or extra support rotor wire. So, Dr. Hongye, do you think that the behavior of the Xiong wire is more similar to the floppy wire or support wire?
Yes, right, yeah. Yes, I would like to review the guide wire bias in my lecture.
Yes,
But the workhorse wire is pretty similar with floppy wire.
Yes. What do you think, Dr. Chai? The stretch. Okay, Dr. Huang, do you have to do the rotor operation, right?
No.
Oh, you just begun to do the rotor.
Yes.
Okay. So what's your rotor operation strategy? What bird size and what wire do you choose?
I agree with Dr. Hong. Yeah, I will choose 1.5 rotor to do rotor operation from at the middle LAD. I think I will part in plasma LAD and only ablation middle LAD segment.
So do you use a floppy rotor wire or extra support rotor wire as suggested by Dr. Hong Ye?
I think if we want to monoablate the multibuccular calcium, maybe extra support wire is needed for this case. So maybe I will choose extra support wire from Dr. Hong's suggestion.
Okay. Dr. Huang, you go ahead and do your case. And so can we shift to the room 2? Dr. Cai Chuan-Cai or Dr. Deng, can you hear us?
We can hear you.
Yes, but can you introduce your case?
Yes, okay. Can you hear me?
Okay. Well.
Okay. Good morning. And our case is a 65-year-old man presented with exertional dyspnea for several months. His underlying disease with heart failure and diabetes, and his risk factors for CAD are advanced age and diabetes. Echocardiography was done and showed LV systolic dysfunction with LVEF 25%. So coronary angiography was indicated, and the findings are shown as follow. Next. Well, as we can see, the RCA was total occluded from the ostium with a blunt proximal CTO cap. And next. The LAD and left circumflex were patent. And next. And we can see a collateral circulation retrograde goes to the middle of RCA from the LAD septal branch. And next. So our target is the RCA ostium CTO with a blunt entry and great angle blending, and more than 2 centimeters long. So so that's our target today. Thank you.
Can you hear me?
Okay, very clear.
Oh, sorry.
Please introduce your team first.
Okay. Thank you for your comment. It's my great honor to share this case with you. And my first assistant is Dr. Cai, and the second assistant is Dr. Chen. Today, can you see the angiogram?
Okay.
As you can see, this is RCA CTO segment at proximal. I see a proximal CTO. So from the RAO view, we can see many retrograde collaterals. However, the really interventional collateral we can choose. In the beginning, we find out one collateral at S1 and S2. Two septal collateral and 2 epicardial collateral.
So you would like to do the retrograde strategy first, right?
Yes. My first strategy is to try retrograde wire crossing.
Mm-hmm.
If I failed, I will shift to kissing wire technique, and then antegrade.
Yes.
So if I shift to antegrade approach, I will check IVAS from cornus branch.
Yes.
However, there is one very tight lesion at cornus branch ostium, so I will inflate the balloon first and check IVAS. So this is my strategy. So next, my first step is I try to put my wire to cross the retrograde collateral.
Okay.
And yeah,
Okay.
however, when we do the super selective suggestion of S1, as you can see.
Okay. Just wait for a moment. I would like to ask our panel's comments.
Okay.
Yes. So the Dr. Deng will do the retrograde first, and then prepare the antigrade later. And maybe ROVUS is very important in this case. So Dr. Tsai, what's your strategy in this case?
Do you have down the CT angiogram? Because I just concerned coronary abnormality. Sometimes the RCA is from the left side, so we can see the angiogram with the atrial branch connected to the RCA proximal. So, do you have bilateral simultaneous angiogram?
Angiogram, okay.
Bilateral simultaneous sequential bilateral injection.
Yeah. Because the CTO ocean is total occlusion. D 组。Can you see here? Can you see that?
So
yeah, this is really a concern that Dr. Tsai, there is a possibility of the RCA atresia. We were one case before that do the RCA CTO. So apparently we found that it proved to be a atresia of the RCA proximal.
That's right, but
I think this patient is a very big heart and very with poor heart function. So before the intervention, Dr. Dan, do you do the IVP or the PCPA support for this patient?
Yeah, because actually it is a cheap patient. So he has diabetes and chronic kidney disease, and also LVEF only 25%. So we put IVP before the procedure to make sure the safety of the patient.
So for this charge case, what's the comments of the Dr. Zhang?
Yeah, I think one very interesting issue is that the etiology of heart failure, the LVEF is as low as 25, but the left coronary artery looks relatively healthy. So we have only a disease RCA, which is, of course, the territory is quite big. So do you think that the ischemia is the etiology of heart failure, or there's some other underlying etiology? And are there any, and about the wall motion, are there any specific worse motion, worse segment?
Yeah, from the cardiac, there's no valve problems. So, and inferior wall is a little hypokinesis. So in the beginning, I think the RCA-CTO is the coupling region to expand while the EF is so low. And the territory of RCA is quite big. So, yeah.
So I think maybe there's more than one etiology. Other than ischemia, there's maybe some other disease. But since RCA territory is quite big, and as Dr. Deng said, it's some hypokinesia, not a kinetic. Of course, if we have thallium scan, it's best. But it seems reasonable to treat our right coronary artery, but with this low ejection fraction, I think we should be more careful during the procedure. And I agreed with the strategy of primary retrograde, because it's occluded right at the outseam, and it's usually very hard to achieve a very good support of the guiding cast, or even a good alignment with the takeoff. So we have several interventional collaterals. So I think retrograde approach is, I agree with this strategy. But of course, with this low ejection fraction, if we go retrograde, we have to pay some more attention about the hemodynamic.
Yes, and how about Dr. Javin? What's your comment?
Good morning. I totally agree that Dr. Zhang's opinion that the patient has such a low ejection fraction down to 25% only, but looks good at the left coronary resistance. So I would also wondering that is there any viability in the RCA territory, since that if the inferior territory is all infarct, I don't think that this high-risk procedure will help the patient a lot. Seems that the chief complaint of the patient is the heart failure symptoms, but not the angina. So personally, I will do the nuclear test or MRI to check the variability of the RCA territory first. And secondly, to the technique aspect, I will, of course, it's a good indication for primary retrograde approach, but eventually you have to do the antegrade. So personally, maybe I will just wire the corners branch first. One, maybe you can do the IVUS pullback to search for is there any occluded austin, and also for the anchoring for the JR guiding caster. In order you to have to do the contralateral injections. So I agree your procedure to do the primary retrograde first, but maybe you can also prepare the antegrade just a little bit.
Yes, thanks. And I think that antegrade and the retrograde both are very, very important for this case. But of course, the antegrade approach with IVUS check is very important. So I would like to ask Dr. Hongye's comment. Do you think that the corners IVUS pullback will visualize the RCA plasma very clearly?
Yeah, I hope so. Yeah, it is important to check the characteristics of fibrous cap. If it is calcified or it is pretty soft tissue, or if you can see some microchannel inside of the entry of CTO. So it is important to check to visualize the entry of CTO by IVUS.
Yes, but you can see that actually there's nearly no stem of the plasma RCA. So I think the guiding cases selection is very, very important for the provide the support and the cohesive. So Dr. Deng.
Yes.
What's your progress now? Can you show us?
Okay. So next, in the beginning we tried to do the super selective injection of S1 and S2, but as you can see. This is S1. Actually, no very obvious collateral connecting to RCA. So we do the next S2. Next. This is S2 injection, constant injection, but still no very good connecting collateral to RCA. So our final choice is the more distal collateral. Next, like this one. So actually, my Caravelle, I use Caravelle, but my Caravelle is almost all in now. So okay, next. As you can see, my retrograde CNY can go up to distal cap with the Caravelle. And then I do the antegrade preparation. Actually, because it is one stenosis at corners branch ostium. So as you can see, Sion blue is very difficult to go into the corners. So we use Mamba microcaster to give more support, and we shift to build the FCY, and finally we can go into the corners branch. And then after 1.5 balloon dilatation, we check the IVAS from the corners branch. And Dr. Huang, so can you explain the IVAS?
Okay, Dr. Huang. Okay. So this IVAS is put back from the corners branch?
Yeah, because, yes, because the pullback length is very short, so the information is poor. But we can see from the corners branch, we put back from through the RCA Austin. And this is the corners branch, and here we're into the RCA side, but due to the poor information, so we cannot see the re-entry point into the CTO.
Can you do the IVAS again?
Yeah, okay. So okay. Now I do a real-time IVAS check because from angiography we can see there is some calcium at RCA proximal cap. So the Austin of CTO might be difficult to see because of the calcium. However, I check the real-time IVAS to try to make sure where is the exact OCT Austin. Because of the support is not so good. However, I slow push and hope to check the Austin.
You do the real-time IVAS check now?
Yeah, yes.
Because we cannot see the image.
Okay, live. Okay, so this is from corners branch. I slow pull back. Here, from 11 o'clock, you can see RCA Austin border. Here, can you see that? Here?
Okay.
Yeah, sorry, 1 o'clock. 1 o'clock. 1 o'clock, can you see that? You can see a border of RCA CTO. And then I go more proximal. After this view, now, here, the Austin is in 1 o'clock. However, some calcium is there, so maybe sorry, some problem with the IVAS.
But I think that because the corners is nearly perpendicular to the Austin, and sometimes IVAS is not some image is not so satisfactory. So what's your opinion, Dr. Hongye? Sometimes the IVAS tester is the angle is too big. So the image may be some unsatisfactory. So do you think that the volcano IVAS Eagle Guy is better for in this situation, or other strategy to improve the image quality?
Yes, but the volcano IVAS is quite bulky, so I'm not sure that the IVAS, even with eagle eye, can visualize the entry of CTO. Oh, right here you can see some entry at 1 o'clock, 1 to 2 o'clock, and some heavy hard tissue can be seen on this view right here. So probably some hard entry could be expected, so that the use of the Gaia wire could be a choice, not like XDR or XDA.
You suggest that use floppy XDA wire or SDR wire for the first wire?
Yeah, because the entry of CTO looks pretty hard, so XDR or XDA cannot be past the lesion.
Yes.
So I would recommend to use Gaia wire to start with.
Yes.
Dr. Hongyan, are there any tips and tricks at this moment to enhance the visibility of the entry? You know, sometimes we pull back manually. I mean, do you think there's any tip and tricks to help us to get more information about IVUS?
Okay, so I recommend to use manual pullback. Oh, you can see some other segment here. But the manual manipulation is very important in this kind of very short and limited segment to be visualized. Or sometimes you can manipulate the guiding catheter. It's our strategy.
Dr. Deng, do you have any other progress?
Okay. So now.
So what's your next step?
Okay. So my after I check, because we can see a ring calcium at RCA ostium from the corners branch. However, as you can see, from angiogram, here is just the border of the calcium. However, you can see some taper end at the proximal cap. So I believe the small dimple is the good way to try the anti-glare puncture with the Gaia second, just like Hongye Sensei recommend. So I try to put the crusade in and to give some more stability of anti-glare system. And then I will choose Gaia second to do the puncture.
Okay. Use a double lumen catheter and use Gaia is suggested by the Hongye.
Yeah.
Okay. Now we'll move to our lecture. Today we are very happy to have a lecture by the Dr. Hongye. He would like to speak about the IVUS for the calcified lesion treatment of the calcified lesion. I think calcified lesion is very tough and very important for the intervention who try to do the complex PCI. So, Dr. Hongye, please.
Okay, thank you. So, my topic today will be focused on calcified lesions. Calcified lesions are sometimes very hard to expand, even though with vigorous pre-dilatation and drug-eluting stent implantation. So, in that kind of situations, lesion preparation before stenting with a scoring balloon or additional atherectomy is extremely important. When we use rotablator, we have to obtain maximum ablative effect with less complications, such as vessel perforation. Let me review a mechanism of in-stent restenosis. Of course, near-intimal proliferation is the major mechanism of in-stent restenosis. Significant stent under-expansion was another important mechanism in 20% of the cases in this study. In addition, stent under-expansion has been reported to be one of the predictors for in-stent restenosis and late thrombotic event as well. So you should not place stents into undilatable lesions, and adequate lesion preparation before stenting is extremely important. When you use IVUS in calcified lesions, first of all, please try to put IVUS catheter even though the lesion looks very tight to evaluate crossability of IVUS catheter itself. And try to check plaque characteristics proximal to the lesion as well. Sometimes IVUS shows unexpected plaque characteristics, such as soft plaque with deep calcium. You have to change PCI strategy. If IVUS catheter is not able to cross the lesion, then use of rotablator or scoring balloon would be a choice. If IVUS catheter is able to cross the lesion, check location and distribution of calcium. Use of rotablator should be recommended for superficial calcium, whereas pre-dilatation with a regular balloon followed by stent implantation for lesions with deep calcium. Please check position of the IVUS catheter inside of the lumen to understand guide wire bias for effective debulking effects with rotablator. Major disadvantage of IVUS for calcium is unable to measure thickness of calcium due to acoustic shadowing behind calcium, which is different from OCT. However, IVUS is probably able to predict guide wire bias and high-risk segments for vessel perforation, which usually occurs at healthy segment, not at calcified tight segment. Also, IVUS is able to evaluate whole vessel size due to deep penetration to evaluate vessel injury following ablation. So I believe that advantage of IVUS over OCT is to predict probable complications and determine strategies how to avoid them. There are some tips and tricks to estimate thickness of calcium on IVUS. There is one interesting study to compare angiography, IVUS and OCT before PCI in 440 lesions. They evaluate visibility of calcium on angiography, maximum calcium angle and surface pattern on IVUS. On OCT, mean and maximum calcium angle, calcium length, maximum calcium thickness were also evaluated. IVUS is most sensitive in detecting calcium. Please note that angiography was able to detect calcium in about 40% of the cases. OCT sometimes missed to detect calcium because of superficial plaque attenuation and deep IVUS calcium. That means calcium locates beyond the penetration of OCT. They found that invisible calcium on angiography, OCT demonstrated thickness of calcium was thinner than 0.5 millimeter and shorter than 4 millimeters in length. Even though extensive calcium greater than 180 degrees, thickness thinner than 0.5 millimeter was not detected on angiography. In lesions with an IVUS maximum calcium angle greater than 180 degrees stratified by angiographic calcium visibility, calcium thicker than 0.5 millimeter or more can be well visualized on angiography. Even though in lesions with extensive calcium on IVUS but not visible on angiography, final stent expansion can be was significantly larger. That means adequate stent expansion can be expected in lesions with angiographic invisible calcium. Next issue is presence or absence of reverberation. Calcium tends to be thinner than 0.5 millimeter, which was measured on OCT. In contrast, irregular surface without reverberation on IVUS, OCT showed calcium is thicker than 1 millimeter. Reverberation is an artifact of ultrasound, and you can identify multiple echo reflections behind calcium with equal distance. Smooth surface of calcium makes ultrasound beam go back and forth repeatedly. Reverberation can be seen at the site of effective ablation following rotablator. However, in this paper, these findings can be applied only in de novo lesions and cannot be applied to calcium following rotational atherectomy. This is the representative case with irregular surface on thick calcium. Next, the media and adventitia behind high echoic area can be visualized on IVUS. We call it dense fibrous plaque, not heavy calcium. You can recognize vessel border, media, and adventitia behind high echoic area as shown in this slide. In addition, we are able to estimate distance between surface of calcium and vessel border to observe adjacent proximal or distal to calcified segment. Please note that it is not estimation of calcium thickness. As shown in this slide, vessel border can be visualized when you check adjacent frame like this, and you are able to measure distance between surface of calcium and vessel border. It is important to predict ablation site with rotablator before starting procedure, and position of IVUS catheter inside of the lumen may be able to tell you guide wire bias. We evaluated relationship between position of an IVUS catheter before ablation and ablated site following rotablator in 1 millimeter about as shown on this slide. There are some typical findings of IVUS images which have been nicely ablated, vibration, and ball-like appearance. We used Renato wire and rotafloppy wire in this study, and concordance rate was 83%, so that ablation site of rotational atherectomy could be predicted by IVUS catheter position inside of the lumen. That would be useful to obtain maximum ablation with minimum complication, such as vessel perforation. One cautious point, because calcified lesion is usually very tight, so that you push IVUS catheter very hard, then guide wire and IVUS catheter will separate like this. In this situation, guide wire bias cannot be predictable. And after you change a conventional guide wire to rotor wire, please take angiogram to check guide wire passage in the lumen, like this, and location of calcium. When you perform ablation, do not ablate normal healthy segment to avoid probable complications. I think that differential cutting is not true in daily clinical practice. You should avoid to ablate all the way from proximal to distal. You should decide the position of platform. Please decide to ablate where to where based on IVUS findings, as you can see in your first case. After rotablator passed the calcified lesion, then check IVUS again to find if calcium was nicely ablated. If you find reverberation, that means guide wire bias was good enough, then you may consider to use larger size of a burr. I am going to show you one impressive case. The patient had a very tight stenosis in mid-LAD, and IVUS catheter was not able to pass the lesion, so we observed only proximal to the lesion. Coming back to left main bifurcation, please note that IVUS catheter is facing to carina and not attached to the calcium from 4 to 6 o'clock. So in this case, this operator used 1.5 millimeter burr and started ablation from left main to mid-LAD. After the first ablation, IVUS was able to pass the lesion. Coming back to bifurcation, IVUS demonstrated that vessel injury was created at carina as shown here. Fortunately, extravasation was not documented on angiography. We finished the procedure with using Scorflex balloon. In this case, we should have started ablation from proximal LAD to avoid vessel injury. We reviewed how frequently dissection or hematoma was created following rotablator. Group 1 was defined as no injury. Group 2 had dissection Group 2 had dissection less than 90 degrees, and Group 3 had dissection greater than 90 degrees or hematoma. Surprisingly, almost 2/3 of the patient had dissection, and 1/3 of the patient had extensive dissection or hematoma following ablation. In summary, IVUS would be able to predict guide wire bias and avoid probable complications. Even though IVUS catheter is not able to cross the lesion, please observe proximal segment to ostium to understand distribution of plaque and calcium, as well as plaque-free segments which should not be ablated. Of course, you should not ablate lipid-rich plaque as well as plaque-free area. Check both angiography and IVUS to estimate thickness of calcium and to decide which device to use for lesion preparation before stenting. After lesion preparation, check IVUS again to decide additional treatments such as use of a scoring balloon or larger size of a burr. Thank you for your kind attention. Okay, thank you very much.
Yes. And for IVUS used to determine the rotor bird parking and the rotor bird distance, and to avoid unnecessary abrasion. But I ask one question for Dr. Hongye. And some experts suggest that that the speed bias use low speed burr and rotor abrasion, the high speed rotor abrasion. And maybe some experts advocate use low speed rotor abrasion to increase the abrasion hole. So do you agree with that?
Okay, I probably started with 1800, quite high speed. And once, because the passage of rotor ablator burr is the top priority. And after we passed the rotor ablator, and then sometimes we used another run with lower speed.
So you believe that low speed will increase the efficacy?
Yes, I think so.
So
just only after the passage of rotor.
Yeah, because that in Taiwan we can reimburse only one insurance coverage, only one image catheter. So sometimes we have some difficulty in choosing the OCT or IVUS. So you believe that? Do you think that because OCT can measure the thickness, the look more clear for the calcium thickness? So in what situation would you prefer use the OCT or you always use IVUS?
I always use IVUS, as you may know, because of course OCT can measure the thickness of calcium and evaluate efficacy of rotor ablator itself. However, my point is to minimize complications. I mean, we have to not only the calcium, of course, we have to evaluate the whole vessel to obtain effective ablation and minimize complications. So I always use IVUS.
Yes, this is very important. Dr. Jackie, do you have any question?
Hongye Sensei, Ohio.
Ohio,
Okay, as you mentioned that the IVUS cannot predict the thickness of calcium compared with OCT. So, and most of the place outside Japan, the cutting balloon and rotor ablation was not reimbursed. So, do you have any tip and trick to differentiate the first tool for the calcified lesion? I mean that is there any IVUS clue that can imply we can use cutting balloon only, or we have to use rotor instead of cutting balloon?
Okay, and so my recommendation is to use rotor ablator first if you find good guide wire bias and circumferential calcium. So because circumferential calcium is sometimes very hard to break even with cutting balloon. So once you ablate with rotablator burr, just one burr, then the following cutting balloon would work nicely. However, if you find the guide wire bias is not good or eccentric calcium less than 180 degrees, then use of regular balloon or another scoring balloon could be a choice. But rotablator and Ulbalin works very nicely to obtain a good stent expansion. We call it rotavalin.
Dr. Hongye, just like the first case, Dr. Lu has mentioned about the risk of using cutting balloon for those with some eccentric calcium, maybe less than or 180. We have a very healthy part up to the calcification part. So what's your experience using a cutting balloon for lesion like this? It's quite risky to cause perforation.
Okay. So compared to the previous cutting balloon, in Ulbalin, the length or height of arterial tone is quite shorter. So I would use Ulbalin even in a healthy, very eccentric plaque. However, in the case 1, that lesion locates at a very angulated segment. So in that case, the Ulbalin may have some vessel injury. But in straight segment, we usually use Ulbalin even in eccentric plaque.
Since it's very important, you mean that the wall may be safe compared to the wall generation?
Yes.
In this kind of eccentric calcification conditions. Okay, I think this is very important. So thanks again for the Hongye's very excellent talk. And now we may move to the classroom one.
Can you hear me?
Yes. Can you share with your progress?
Okay, so we use the rotaburr 1.5 rotaburr for rotablation. The initial speed we use 160,000. So we can see mild resistance at the proximal AD. After we ablate the proximal AD, we can move to middle AD. The speed down to 140,000 at middle AD. After several attempts, the rotaburr can advance to distal AD, can pass the lesions. So after maybe 4 times rotablation, we polish. So we down the rotar speed to 140,000 once, and this is the final angiograph after rotablation.
Do you check the IVUS?
Yes.
After the rotablation. So
after rotablation, you can see mild no reflow. So we use a 2.5 balloon to predilate the lesion, and the IVUS image is after predilatation with 2.5 balloon.
Okay, you mean that there's some no reflow, slow flow after the rotablation?
Yes, so the blood pressure down to 70 millimeter mercury. Yeah.
I noticed that you have put the patient before the rotablation, right?
Yes. Because the RCA is small, it's hypoplasia, so we worry about maybe bradycardia during rotablation.
Yeah, before the rotablation, from the IVUS, Dr. Hongye has suggested the potential risk of the break for the attenuated plaque maybe you can carry some risk of the slow flow. That's true after the rotor operation. So can you share the IVAS image after rotor operation with us?
Can you see the IVAS image?
Okay, Dr. Huang, please.
Okay. We have shown two IVAS image with everyone. One is the pullback from the LED distal to the Austin. Another is from the proximal to the Austin. We see the first one. We see a first image. It's from the distal to the medial side. We can see the disease-free diameter is about 2.0 millimeter, and we can see the LED. We can see LED distal. The lesion pattern is the eccentric classification. We move to the LED proximal. We can see the eccentric. We can see the concentric classification. And after the balloon dilatation and the rotor abrasion, we create a quick in the calcified region. We move to the finding from the LED Austin. I think we also create a quick in the calcified region, and we move. We see the next image for you. This image is from the LED Austin to the layman. It also belongs to the concentric calcified region, and the layman diameter is about 4.0 millimeter. Okay, thank you.
So can you press the IVAS again for LED meter and yeah. Can you make it break by itself? Okay.
I play from here.
Yeah. Okay. Actually, we can find some minimal reverberation after the rotor abrasion, but
yeah, it's a very big RD.
Yes. So Dr. Hongye, would you suggest that to do more large bird or abrasion or just the balloon?
No, not in this case. Because right here you can see some reverberation.
Yes.
Here, and you already obtained a quite nice lumen.
Yes.
Yeah, and probably it will beyond the rotablator working area. And an eccentric plug, yes. Probably you are able to create a section crack following balloon inflation.
So after the rotor abrasion, there is a slow flow happens. So I think there's sometimes a slow flow or no after rotor abrasion. Sometimes will lead to catastrophe. So what's the strategy for the slow flow or no reflow, Dr. Tsai, after the rotor abrasion?
One quick comment. If you look at the very distal vessel, you can see the media and very clearly. So here, yes. Media clearly, and internal high echoic air band can be seen. So probably this area is spastic. And yes. After following nitroglycerin injection, yes. Then the true vessel size would be about 2.5 millimeter.
2.5, yes. This is very important. Chief Chang, how to treat the slow flow, no reflow after the rotor abrasion? But sometimes the slow flow is transient. But if the persistent slow flow, that's very into very catastrophe disaster. And so how to treat the slow flow, Dr. Jabin? Would you use only nitroglycerin or use the adenosine, something like this?
Well, usually we would prepare the cocktail on our table. So if we have facing this kind of a slow flow phenomenon. But I think for the technique for the rotablation, sometimes if you too aggressive, I mean that you ablate the lesion too quick or too not so gentle, so it will increase the risk of slow flow, no flow. So in this contemporary technique for the rotablation, we just do the contact the rotablator gently and slowly, and be patient. So I think that currently the slow flow, no flow phenomenon is quite limited compared to previous technique. So of course, from the beginning, we try to avoid this happen. And once it happens, we just use the cocktail and hopefully that the flow can restore.
Yes, thank you. This is also very important. And the second, I think that actually can we see the next round of the IVUS?
Okay.
We can see that the plaque may extend into the lemon. So I would like to ask Dr. Huang, would you like to, how about your standing strategy? With just only one stand crossover to the circumference, or use the two stand?
I think I will choose one stand crossover from left main to LAD.
So how about strategy, Dr. Zhang?
Yeah, we don't have an image for IVUS image for circumflex, but angiographically, I think it's quite.
We have IVUS from circumflex.
Okay, what is that?
Run three.
Okay.
This is the IVUS from distal circ to proximal ostium. We have put one stent at distal circ, but the stent size may be small, so we use 2.75 balloon for post dilatation after the IVUS image. You can see the middle circ only have stenosis, have plaque. Some plaque at ostium circ, but I think the area is enough, so maybe one stent strategy is okay.
Yes, I agree. So Dr. Tsai, do you agree with the one stent strategy?
It's quite good, quite healthy. So I think I agree with the single crossover one stent strategy.
Well, another comment is that I think we did not disengage the guiding caster whenever we do the IVUS pullback. So we don't have a full visualize of the lemon character. So it can depend on where we land the proximal stent edge to the lemon ostium or only the lemon shaft. So you can see that whenever we pass the carina, the IVUS caster jump into the guiding caster. So we don't have much information for the lemon itself.
Okay, I think we all agree with your strategy, one stent crossover. And Dr. Huang, you can go ahead.
Okay.
So what size of the stent and the lens do you choose?
For distal LAD, we choose a 2.5 and the synergy stent. And after the stent deployment, we can see we confirm the position of stent, and after we confirm the position, we inflate the stent. So I will choose 3.0 millimeter stent from at the proximal LAD to left main, and use 4.0 or 4.5 balloon for part at the left main.
Mm-hmm. Do you have put the stand already? The left main 2 LED?
Not yet, not yet.
Oh, okay. You can go ahead.
Okay. 那3.038。
对的，3.038。
So, how much are you going to cover the left main part? We don't have IVUS image for the whole left main segment.
I don't have the whole IVUS image of the whole segment of left main.
So your
So I think from the angiography the Austin left main is okay. So I think I will not put the stand at left main Austin.
So can we see the quarter view?
Quarter view.
Yes. Yeah. It looks like a very short left main.
Yes.
So after you put the stand, do you want to do the kissing technique for the circumflex or just the leg alone? Just only do the part?
Because the left circumflex is dominant, so I think I will open the stand strap and do the kissing technique and the final part at left main bifurcation.
Some panelists they will do just the only part, not kissing.
No, I totally agree that since we have already intervened the circumflex and it's a quite major vessel, so I will definitely open the opening of the circumflex one day that you have the chance to do re-intervention for the circumflex. So I would do that.
I used to do kissing balloon for left main lesion before, but nowadays I very often I just do parts because there's some data showing that final kissing may not be helpful. Sometimes it could be even worse for the long-term outcome. And so far, in my experience, part only is works quite good. And usually it's not a big issue if you have to recross, even you have circumflex lesion later, you can cross it easily. So nowadays I do not routinely do final kissing.
Yeah, I think there's still some debate for you should do the final kissing. Because I think the kissing, the final kissing also carries some risk of the damage to the circumflex ostium. Sometimes you can see that actually there is just some plaque distributed in the circumflex ostium, and just if you just only ballooning, then maybe cause some minor dissection, always detected by the OCT, an injury of the circumflex ostium. So of course the Japanese concern is real, because they put a stent of the circumflex, and maybe later we will need to intervene the circumflex. Okay. But it looks like the stent is too short, right? It did not cover the lemon.
Yeah, so I will choose another 3.48 millimeter. 3.0 and 48.
Oh, already? The lemon looks like the more than 4.
Yeah.
Yeah.
Yeah, but the distal middle LED maybe 3.0 is okay. 3.5.
I also suggest to use 3.5 for adequate expansion for the left main, because for 3.0, as I know, for Sinich, the maximum expansion is 3.75.
Okay.
The Lebanon looks quite big. Recently, I have some bad experience. I use 3.0, and I expand the stand with 4.0 balloon. And maybe even after 1 year, when I try to do the other procedure, the wire still went outside the stand, and unexpectedly, and I pushed the image caster, and I caused a stand deformation. So I think maybe it's an important issue to have adequate expansion of the stand at left main.
Okay, I agree. Maybe 3.5 is suitable for this case. I think this procedure is okay. How about expert experience, the commendation?
Yeah, it looks good.
Okay.
Can you see from the cranial view or?
Cranial view, okay.
Or aerial cranial view?
Aerial cranial, okay.
So that's the good thing to use the IVUS to visualize all the way from LAD back to lemon. Since that if you can visualize the lemon, maybe it's more than 4. So you will definitely choose 3.5 stand to inflate at low pressure, but you can have the capacity to expand to the optimal size at lemon.
Yeah, yes, I agree with you.
So how about this precision?
It looks good. And just put it from the Austin to the LDB.
Okay, okay. Oh, that's outstanding, okay.
3.6 11个吧。
14。14
哦。
好 ，different。再次。
14再次。
好 ，different。
Yeah, 3.5, right?
Yeah, 3.5.
Yeah, maybe the inflation pressure cannot be so too high because the distal, the basal may be about 3.0 just.
Okay.
So when you use the long stand of 48 in length, very often we encountered size discrepancy between proximal and distal landing position. For the first stand, we choose 2.5, and maybe it's slightly oversized for distal landing part. But to fit the proximal size, sometimes we choose a bigger one. My strategy is to inflate the stand very slowly, one by one, slowly, and usually for synergy, if you inflate up to 7, it's quite safe. Maybe the stand is not fully expanded, but the distal segment can accommodate the distal reference size quite good, and we can always avoid the section, and the taper is quite smooth.
Yes, and because you use a very long stand, a long balloon, when you put back the long balloon, you should be very careful because you stand. The proximal part is not fully expanded by the non-compressed balloon. So if you put back the balloon too quickly, the guiding caster will damage the synergy. So this is a 3.5.
This is the non-compressed balloon, 3.5 non-compressed balloon.
We have another question from our audience that maybe for Dr. Hong Ye, If we cannot pass our IVUS caster, cannot pass the caster across the lesion, how to evaluate the wire bias? The Dr. Hong Ye can answer the question. Dr. Hong Ye. Of course, if we did not have the IVUS image, maybe we cannot just recognize the wire bias from the angiogram and estimate the wire bias with the position between the wire and the calcification.
Well, of course, I think that since that we cannot pass the IVUS caster over the lesions, so of course we cannot evaluate the wire bias at that lesions, which is uncrossable. Yes. And of course, the IVUS is not only to evaluate the wire bias, and since in this kind of scenario that we can evaluate the proximal segments for the like the platform or the strategy for your standing.
Yeah, Dr. Hong Ye. Yes, so the question from the audience is that they ask that if we cannot pass our IVUS across the very tight lesion, how to evaluate the wire bias?
Okay. And after you change the conventional wire to rotor wire, then take an angiogram from 2 or 3 directions. 2 or 3 objections so that you can estimate the guide wire bias. So take an angiogram is very important.
For this case, I would prefer to do a part for the left main first after standing. Yeah, maybe it's safer. We can have the stand fully expand the left main to avoid any deformation.
Yeah, of course. So before the wire cross to the circumflex, we have to do part. Yeah.
I mean, maybe before do high pressure post dilation for LAD, I prefer to do a part for left main first. I think it's safer to avoid any deformation of standard left main.
And one common questions for the IVUS during rotor ablation is that why not we just use the rotor wire to do the IVUS? Because of usually we use the workhorse wire to do the IVUS, and we predict the rotor burn course during the rotor ablations. But sometimes the behavior of the rotor wire to the workhorse wire is quite different. So the common question is that why not we use the IVUS over the rotor wires? But usually we don't recommend that because the rotor wire is quite fragile. So sometimes it is very long, it's very difficult to manipulate. Once you damage the rotor wire, when you do it in the IVUS pullback, sometimes you will have some difficulty to do the further rotor ablations.
Yes, I think this question is for Dr. Hong Ye. Would you prefer you do the IVUS from the rotor wire?
So firstly, I use conventional wire for to check IVUS before rotor ablation, because as Dr. Lin mentioned, that rotor wire is very weak or fragile. And in addition to that, rotor wire is the 0.1, so the thinner or smaller profile than conventional wire, and it may have some movement inside of the vessel. So I recommend to use conventional wire. But during the procedure, we use IVUS repeatedly, and in that situation, we use rotor wire with IVUS.
I note that some expert, especially OCT expert, was suggesting, especially some paper published recently, that if you do the OCT guide PCI, some PCI entire intervention where you choose the birth size according to the OCT image, and the birth size choose will be larger than the IVAS, just only IVAS guide PCI. So from the point of view of the OCT image, maybe sometimes some expert will you choose larger bird, maybe 1.75 for the first bird. So what do you think, Dr. Hong Ye, for this strategy? That larger bird, yeah.
Actually, I cannot comment because I don't use OCD in our cath lab, and I believe IVAS measurement with IVAS. So. And actually, the size looks smaller on OCT than IVAS. So usually, the use of regular balloon, the quarter size up is usually recommended based on OCT measurement, I think. So, but I don't know.
Yes. Okay. Dr. Huang, do you want to check the IVAS after the standing? Or can we see the image?
Yes. Image? You can see now we do the IVAS. You can see a real-time image.
Okay. Dr. Huang,
yes.
Dr. Huang Weijie, can you interpret the IVAS? Well, very distal LED, that it looks like the stent was very well expanded. Dr. Weijie.
This real-time, the wrong system.
Real-time image.
Real-time, okay.
Okay, looks like stent were very well expanded, very wrong, and this is maybe more than 2.5, nearly 3. I think this is very calcified part, and some epsilon in shape, oval in shape. Okay. The lesion is too long, and
yes.
They have to do second round of IVAS. Okay, this is from the mid. Okay, from the middle.
Okay.
Back to the element. Okay.
Okay. Please disengage the guiding caster.
Yeah.
Okay.
Yeah. Okay.
This middle part of LED.
Yeah. Yes.
The stage element is very well expanded, very well good position. So, yes. But I think that the whole length of the standing part makes the stand expand very well, but the middle part is some oval in shape, a little bit under expansion.
Yes.
So, do you think that we need to do the post dilation, Dr. Tsai?
It's okay. Maybe no need another.
3.5的 NC 我们要打大一点。
Well, in my view, that during this run we have some under expansion at the very distal part, about 5 millimeter. So I think we may have to do more aggressive post dilatations, no matter by 3.5 or 3.0. Maybe 3.0 first to do the NC high pressure post dilatation, and then we will check the IVUS to do 3.5 or not.
Dr. Hong, could you show me the minimal stent area in the last round?
Stent area, okay.
Maybe around here?
Yeah,
maybe
here,
around
okay,
here.
okay.
We just passed.
Measure the stent area.
Around 5 millimeters.
So
maybe go distally a little bit. From
okay, one more minute. 帮我量一下 stent area. Okay. 帮我量 stent area.
So it's another question about the after standing and optimal lesion prepare. If the minimal stent area is just around 5.5 or less than, but the stent will contact with wall. So we need post dilate more high pressure, more aggressive. How about your opinion?
But sometimes this lesion is located at the total part of the vessel. Sometimes it's very eccentric part of calcification. So even we do the very aggressive post dilatation, maybe we cannot correct the void shape of the stent. So if we always do the post dilatation, but if we have achieved more than 4.5 millimeter adequate stent area, then maybe we can stop there.
So maybe you can click the dynamic review button at your left lower corner to more facilitate your accuracy for track the instant area. But I think in my view that the instant minimal stent area is even less than 4. So I think it's a quite independent predictor for future event. So I would personally to do more aggressive post dilation here.
Yes, I think so.
So Dr. Huang, maybe we all agree that we have to do the post dilatation here.
Okay,
Maybe 3.0.
Yeah, I will use 3.0 non-confined balloon for high pressure post dilatation.
Yeah, and then you will do the final casing for the LED and the circumflex and the final part, right?
Yes.
Okay. Also, thank you for your excellent demonstration of the calcified lesion and non-diffuse lesion. And we also thank our distinguished guest, Dr. Hong Ye, for joining us to discuss this, join the ROVUS Live. And we also thank our panel. And because time limitation, we have to close the first section. And maybe we can come back 10 minutes later. We have 10 minutes break. Okay, thank you.
Thank you.
Thank you. Goodbye.
Thank you.
Goodbye.
Goodbye.
the second section of the ROVUS lab. And in this section, because it should be chaired by the President Xie Yizhang, but now here another meeting, so he will come here maybe half hour later. So I am here still to chair this section. And in this section, we are happy to have our distinguished guest from the Kokura Memorial Hospital, Dr. Soichi Kuramizu. Dr. Kuramizu, do you hear me?
Hi, I can hear you clearly. Thank you for inviting me. Yeah.
Yeah, we are happy to see you. We know that Dr. Kuramizu is also a very famous ABAS expert in Japan. And we have others commentators. And again, on my right hand side is Dr. Cai Zhenping, and my right hand side is Dr. Chip Cao Dianping, who is from the Zhenjiang Memorial Hospital, and the left hand side is Dr. Lin Xiabing from the Taipei Memorial Hospital. And in this section, we have the one case of the CTO, RCA CTO case for the classroom 2, and then we will another case for the rota operating classroom 1. So first, can we go to the classroom 3, classroom 2? We will come back.
Okay.
What's your progress?
Okay. So, okay. Can you see the angel? Can you see the angel come?
Yes, we can.
Okay. So we check in the beginning. We check the RCA Austin, and we can see a small dimple there. So we try to use the Crusade caster to stabilize the integrated system.
Oh, well, that's the, excuse me. That since we have already changed our panels, so here we have President Xie Yizhang, and also we have Cao Dianping. So, and also we have a distinguished guest from Kokura, Shoichi Kuramizu. So can you introduce your case from the beginning, because most of us is not familiar with your case.
Okay. 看诊断。Okay, this is an RCA CTO region, and so from the angiogram, we can see CTO segment is located in the proximal, and some retrograde collateral from septal and epicardial to the RCA middle, as you can see. And this CTO segment is quite more than 20 millimeter, and the angulation and brown end. So the JCTO score is 3. So according to this finding, we try to do retrograde approach first, and we do the supersedation from the septal. But unfortunately, S1 and S2, from S1 and S2, we cannot find the optimal, the best collateral, connecting collateral. So finally, we go to the LED very distal and find the septal collateral, as this angiogram. And then we use the Sion wire and the carbell, and then we can go to the RCA proximal, RCA middle, as you can see now. And then we use the retrograde wire as a marker, and then we do the anti-grade preparation, and we check IVAS in the beginning and confirm the CTO Austin is just like located the very Austin, as the angiogram you can see now. A small dimple is the entry side. So then we try to use Crusade caster to stabilize the integrated system. However, the attack angle is very poor. So we do we use a small balloon anchor in a corner flange and try to do anti-grade puncture again. So this is the best angle we can this is the best angle we can adjust to fit the guiding caster and to the RCA CTO proximal cap. However, we try to use Gaia second wire and do the anti-grade puncture. However, because of I meet some difficulties to do the coaxial of my guiding caster and CTO proximal cap. Because from lateral view, I can do a best coaxial, but from the frontal view, I cannot. The guiding caster cannot touch the CTO proximal cap. So it's quite difficult to do the anti-grade puncture. So and then I shift to retrograde puncture with a UB3. However, it's very difficult to break the distal cap. So I shift to the concrete floor and try to break distal cap first, and then I will downgrade the guide wire to test the CTO. However, although the concrete floor can go more distal to RCA proximal like this angle, the curve is not so good, and the hand feel is not also not so good. So I downgrade to the UB3 and try to pass the CTO. Yeah.
I'm Dr. Chao Dianping.
Yes.
You've done a very good job. And I see the patient has IABP. What is the situation of the patient?
Oh, okay. So because the patient is also a chip patient, his LVEF is only 25%, and also a CKD patient. So before the procedure, we put in the IABP first to make the patient make sure the safety of the patient.
Okay, this is Dr. Xue Zhang speaking.
Yes.
Did you consider to use another type of guiding catheter, for example, short tube Amplas, to increase the support of guiding catheter?
So that is a very good situation, because in the beginning we try to do the best coaxial, so I choose JR guiding, but actually it's still difficult to do the best coaxial. So I need your suggestion to decide the next step. And because the retrograde UV3 is still difficult to advance, so now I shift back to the concrete floor, and I can show you what does the work. So now
Dr. Dan, I'm Dr. Tsai.
Yes.
Because we have a CT angel, we cannot identify the RCA proximal portion, his anatomy. So in this condition, you puncture retrograde, puncture the distal cap. I would suggest you try to use the relatively softer tip wire with polymer jacket wire to drill the lesion. Maybe you can make if the practice is softer, you can have a chance to advance more.
Okay. So
another suggestion is to use a very hard wire from the
from the right coronary artery, puncture the cap, but normally it will go into the subintimal space, and then you can use the knuckle wire, knuckle down to the mid segment, and then probably you can do the reverse cut. Yeah.
Okay. Okay, so this is concrete floor 12, and now I will shift to software wire.
You can perform step by step.
Okay.
First, use a relative soft wire as Dr. Tsai suggests. Okay.
Okay, thank you. 那给我刚 UB3在吗？
Hello, so Dr. Kuramizu, do you have any comment for this situation, current situation?
Yes, actually, this case is a real chip case. So having CKD and low EF, and also the region is so tough because the region is occluded from the ostium of right coronary artery. So in this situation, as already commentator mentioned, the knuckle wire via retrograde is much safer to identify the vessel line. So if I'm operators, so I try to perform knuckle wire, so using sewn block polymer jacket wire, and then so I use the knuckle wire as a target of antegrade wire. This is my opinion.
Okay. So Shi, please continue your work because we have to move to the room 1 to see the final result of the case. Thank you.
Okay,
we'll come back very soon. Thank you very much. Thank you. Okay. So, Sao Song.
Yes,
I'm
here.
We are back.
Yeah.
Can you explain what's your procedure?
Okay, after we put the 3.5 stent, we can see the IVAS, the stent area was not enough. So we use a 3.0 non-compressed balloon for high pressure post-dilatation. We can see the final angiography. After the post-dilatation, we use a 3.5 and 3.0 balloon for left main distal application kissing technique, and 4.5 balloon for PAC left main. This is the final angiography. We can see the LAD looks like the chemistry flow and it's okay. We can also show the IVAS image after high pressure balloon post dilatation. Do you want to see the IVAS image?
Yes, of course. Please show us the result of IVAS. Thank you.
This is the final IVAS image after high pressure post dilatation from distal, from middle LAD to left main. Initially, this stent area was not enough, but we can see now the area is okay. But the heavy calcified lesion, you can see the shape of stent was not circle. We can see this oval shape because the heavy calcified lesion here. So this area was not very good, but the stent area is okay. This is the proximal LAD. This is the circumference and the left main. You can see. Okay. So I think the final angiography is okay. Is any recommendation from the commentator?
Dr. Huang, it's a quite nice job after you did the high pressure post dilatation for LAD. So do you have the now the minimal lumen and minimal stent area after high pressure post dilatation? And also, do you have the circumflex pullback? I know that you did the kissing balloon, so we would like to see if there any damage for the circumflex ostium, or you did not do the circumflex pullback.
Yeah, I don't have the final image from circumference because time limitation. So I only have the final IVAS image from LAD.
But it seems to me that the minimal stand area now is quite adequate compared to the situation before high pressure post dilatation.
Yes.
So initially I think the minimal stand area is even less than 4 millimeters square, but currently to my eyes I think it's at least 5 or even more than 6. It's quite expanded compared to the previous one.
Yes, yes.
There is a very good demonstration about the IVAS sky for the heavy calcified diffuse lesion. Usually, after standing, even where lesion prepared by the IVAS view, the stand is well opposed. We usually forget to measure the minimal stand area. Just like this case, after a measurement, some segment, the minimal stand area is less than 5.5 millimeter square. So we need the most aggressive post-dilate to lumen gain. So it's very good job, Dr. Huang. Thank you. Thank you for your very good demonstration.
Thank you.
We have to, it's our honor to invite Dr. Soichi Kuramitsu to give us the next speech. And Dr. Kuramitsu currently is the consultant of the Kokura Memorial Hospital. And as we know, he performed a lot of complex PCI. So today is our honor to invite him to give us a speech, special lecture. The title is IVAS for CTO region and the clinical role of IVAS in CTO PCI. And as we know, Dr. Kuramitsu also the expert IVAS performer. So please go ahead with your speech, Dr. Kuramitsu. Thank you.
Thank you, Chairperson. So I'm honored to be here. So my topic is clinical role of IVAS in CTO PCI. So what is the clinical role of IVAS in CTO PCI? So I think clinical role of IVAS in CTO PCI mainly consists of 3 roles. So first is to confirm the position of guide wire at CTO entry and sometimes exit. And second is to facilitate reverse cut. And third, IVAS guided wiring. So, today's time is so limited. So I'd like to talk about the first and 2 roles. So why is the most important point in IVAS when performing CTO PCI? So I think it's to identify where the wire is located in CTO region. So before talking about the IVAS in CTO or region, so we should understand the histopathology of CTO region. So as shown in the left pictures, so CTO region pathologically consists of 3 components: intimal plaque, medial, and adventitious. And in IVAS, the CTO region consists of 2 components: intimal plaque and subintimal. And when you treat the CTO region, you should identify whether the wire is located in the intimal plaque or subintimal space. So this is the first step. And this is a typical IVAS image of subintimal space. So this area is intimal space, this area and subintimal space. Okay. So after recognize the guide wire position in CTO region, so you should consider what to do next. Okay. So I'd like to talk about, so first row, so to confirm the position of guide wire at CTO entry and exit. So this is the first case. The region is CTO in mid LED. So as shown here, the region is not so long, okay? And there are big septal. So we start with IVAS. So IVAS pullback from septal branch to confirm the CTO entry. And actually, this case has the proximal cap is so hard, the stiff wire with the lumen caster support is necessary to advance into the CTO region. So looking at right angiogram, so cranial view, it looks okay. So this is a IVAS from the septal. So actually, so we try to confirm the guide wire position at CTO entry. So this is a septal, this is a main branch. So actually, this is a manual IVAS pullback. So it's a little bit difficult to find out a guide wire in this case. However, I think this is a guide wire. So this is a key IVAS image. So once again, so guide wire is here, just behind the calcium. So it means this is a subintimal tracking. So indeed, so even though there we advance guide wire distally, so we cannot get the distal movement. So according to the IVAS and the angiogram finding, so guide wire advancing into the subintimal space. So, you know, once guide wire migrate into the septal space, so it's difficult to cross subintimal space to the distal lumen. So that's why, so you should check the guide wire position at CTO entry using the IVAS. Okay, this is a key point to get a success here integrated approach. So according to the IVAS finding, so we puncture more proximal pod using more stiff wire, Compass 820 with Sasuke support. So finally, we get the distal movement. So this is IVAS. Okay, so this is the IVAS pullback from septal branch. This is the main branch. This is the second guide wire. Yes, this is the second wire here. And this is the first wire. So this is the summaries. So once again, so second guide wire go into the intimal part. So first wire just go into the subintimal space. Okay. So this is the final angle. So we get a success. So using the IVAS support. So here are key point of IVAS interpretation. So when checking the guide wire position at CTO entries. So like this case, so when guide wire is located close to EM, so margin of vessel, it is at high risk of subintimal tracking. So that's why we try to puncture of center of main branch. So when the IVAS show the guide wire is located within the intimal part, you can keep going. Okay. So this is the second case. The region is subtotal. It met circumflex. So we start with the normal wire shown and macrocaster. So unfortunately, shown is easily advancing into the subintimal space. So we perform the parallel wire technique. So fortunately, guide wire pass through the CTO site. to the septal branch, side branch. So this is a manual probab from the side branch. So actually, we can make sure we can get this the true lumen of side branch, and this is the main branch. So actually, it looks okay. So however, we cannot get the advanced guide wire into the distal true lumen of main branch. So actually, I was already showed the answer why we cannot get the distal true lumen of main branch. Once again, I will show you this IVAS. This is please focus on the temporal. This is the main branch. We can find out the blood flow of main branch, and the little bit difficult. However, we can see the plaque flap at the ostium of main branch. So this is a schema explaining this situation. So this is the main branch, this is the side branch. So we can see the plaque flap. So cover the ostium of main branch. So according to the IVAS finding, so we can understand guide wire takes a shortcut from the intimal plaque to the distal true lumen of side branch. So this is animation. So actually the plaque flap cover the ostium of main branch. So that's why the antegrade guide wire cannot be advanced. In this situation, so reverse guide wire technique is very useful. So like this. So in this case, according to the IVAS finding, so we try to perform the reverse guide wire technique using Sion Block and Sasuke, so the lumen caster. And finally, so we can get the distal true lumen of main branch. So the key point of this case is to interpret IVAS finding, okay? So this is the IVAS after reverse guide wire crossing. So we can see there some hematoma, so around here. However, we can get the distal true lumen of main branch. So this is the final angiogram. So actually the severe spasm occurs the distal edge of the stent. So however, there are no HG section in IVAS, so we finish this procedure. So I'd like to talk about second law, so facilitate of reverse cut. So you know the reverse cut is well established technique in the contemporary PCI errors. The basic concept is bilateral wiring and valve dilatation and the retrograde wire passing. Okay, so honestly, the IVAS may be not mandatory to complete reverse cut in all cases. So, however, in some cases, it is difficult to complete reverse cut. So only angiogram. So what should we do? So the answer is very simple. So IVAS. This table shows the IVAS algorithm for reverse cut. So according to the guide wire position of antegrade and retrograde wire, the IVAS pattern are classified into four patterns. So intima, sub and plug, plug and subintima, and sub and sub. Okay. So after recognize this IVAS pattern, so you should consider what to do next. So this is the first pattern. So sub and sub. So both wire exist within the subintimal space. So in this pattern, you should try to perform reverse cut again. Okay, maybe you can easily get the success in this pattern. Second pattern is intima and intima. So both wire exist within the intima. So in this pattern, so you should try the kissing wire cross advancing the anti-gravity guide wire. So if fail, so you should try the flowing technique, reverse cut again, then reverse cut, guide wire, guide extension, reverse cut. So third pattern, so intima and sub integrate within the intima, sub retrograde in subspace. So first option is integrate wiring. Okay, so if fail or to the subintimal space, so you try to reverse cut again, like this. And the third pattern, so reverse cut with a bigger balloon enough to make medial dissection, and advance the retrograde guide wire again. So this is the last pattern. So antegrade sub, retrograde intima. So actually this is the most difficult pattern. So when treating CTO. So in most cases, the lesion showing this pattern so include a severe calcification within the CTO region. So first option is intentionally advancing retrograde wire into the subintimal space. And the second option is retrograde guide wire crossing with IVUS guidance. So in this option, so you should take care of the guide wire, retrograde guide wire position. So because the retrograde wire sometimes go outside the vessel. Okay, so that's why you should use the IVUS to confirm the retrograde wire position. Okay, so this is my take-home message. So IVUS played a crucial role in getting high success rate in CTO PCI. The most important point to identify where the wire is located in CTO region, and then so you should consider what should we do next based on IVUS finding. Thank you for your attention.
Thank you, Dr. Karamis, for your outstanding talk regarding the IVUS guided CTO PCI, because there's a progression of room 2. Can we move to room 2? Hey, Xi.
Hey.
Yes. What have you got so far?
Okay. 看一下那个 we change the SL guiding caster and do the anchor balloon again, and we push the mamba caster and the soft wire, and we found the soft wire can advance a little bit, and we try to engage, use the microcaster to engage the loose tissue part and try to do wiring again. And so this is our current position, and I will use software.
So in right coronary artery, there's two. You are in the two branches, right? One is
one is the current branch.
The other one is that one. The second one is also a branch, right? Or
I guess because there's no resistance.
And is that a microcaster or double loop caster?
It is a mamba microcaster, monorail.
Okay.
Let's try to engage SL better. And do the wiring again.
But from the movement of the wire, your device, all devices are in the, I think, the vasculature. So probably you can change, you can use a harder wire.
Okay.
Puncture the cap.
OK。那我们换一下那个，我看有个 Congress form， 看有 Congress form。
Well, now we can have the better backup support for the anti-grade wiring. So I agree with Chief Cao that now maybe we can just try to use the stiffer wire to the anti-grade wiring. No matter we get into the true lumen or subintimal space, that maybe just can be ready for the reverse cut.
Okay, thank you.
And I have questions for Kuramitsu Sensei and Shoichi Ohio. So in your lectures that you just, because of the time limit, of course, you cannot touch every topic regarding the IVUS guide in CTO interventions. So my question is that usually after we cross the CTO lesion, we have the distal negative remodeling vessels. So sometimes it's quite difficult to decide the stent size, because usually the distal negative remodeling size is plaque-free, but usually very small. But we know that after recanalize the CTO, sometimes the distal vessel will go larger after the interventions. So what's your strategy to choose the distal stent sizing regarding this issue for the negative remodeling after CTO recanalize?
Thank you, Chapin. So actually, that's very important and difficult to answer. So however, it depends on the situation. So as you mentioned, if the distal landing zone looks normal, so if so, we could choose a stent little bigger size, so according to the EM size. So however, in some region, CTO region, getting bigger, so during the follow-up. So actually, if the IVUS show the perimedial high echoic band, PHB, you should, maybe you can choose the bigger stent. So, however, if not, you should choose stent size carefully. Maybe EM or inner sites, lumen sites, it's a safer choice for the stent sites.
So I just follow the question. So normally we check EEM to EEM for the vessel size, or some operator that they use lumen size to decide the stent size. So what is your opinion about the choice of the stent according to the IVUS image? Some operator they use EM to EM plus vessel diameter and divided by 2. that is the stent size they choose. So what is your opinion about the?
Okay, thank you. So in my daily practice, so I usually use the lumen diameters. So because the current DS get a great result, so compared with the previous DS. So, and in my clinical practice, so when the lesion looks normal or the plaque is fibrous, and we choose the greater lumen diameter plus 0.25 or 0.5, so as a stent size. So, however, on the other hand, the plug has some plug or some repeat plug or some calcified plug. So we usually choose greater lumen diameter, so as a stent diameters. So because there is some risk for edge dissection, so when choosing a bigger stent size, this is my style.
Thank you. See, I think there's some progression, huh?
Thank you for your suggestion.
Very good.
The curve looks acceptable.
I think the wire is still in the vessel, so this you can keep on advancing the wire.
So this is the Conquest Pro, right? Is it?
Retro, yeah. Anti-glare and the retro go. Yeah, anti-glare is Conquest Pro.
Actually, knuckle wire is more safe than advancing the very steep wire in this kind of situation.
Okay. So your suggestion is we do retrograde knuckle wire?
No, anti-glare knuckle.
Anti-glare knuckle. Okay. I try to advance半把more.
Because now we have no idea where is the anti-gray wire, so maybe I would try more retrograde wiring. Just try to keep these two anti-gray and retrograde wire as close as possible.
Okay.
So your retrograde wire is stuck here? Or you can advance. It's stuck in the retrograde wire.
I still can advance a little more. However, the curve, I'm not sure is it correct or not.
So it's still the UB3 or?
No, it is Conquest Pro.
I mean the retrograde.
Yeah.
Oh, both anti-grade and retrograde are Conquest Pro.
Yeah.相对个人。
Well, Shoichi, so in this kind of situation, what's your suggestion for the?
Yeah, thank you, Chapin. So I think little bit difficult to advance the Compress Pro, so via anti-grade and retrograde approach. So I think the more floppy wire, so prima jack wire, so like a Sion block. So it's better via retrograde. So actually there is no milk mouth in this situation. So that's why I recommend you you should advance the retrograde wire. So Sion block or something. So here as a milk mouth. So for the anti-grade wiring. So, the compressed Pro is easier, it's likely to go outside the vessel. And that's why you should take care of the wire position in this case.
Okay.
Now the two wires direction looks good.
So now you change your anti-grade wire to
Sion break.
Still black?
Yeah.
Okay. So, Dr. Cao, why you prefer anti-gray knuckle but not retrograde knuckle?
Because it's safer to advance the anti-gray wire with the knuckle wire technique, and then you also can do the knuckling from retrograde, post knuckling, and that is a safer way. Yeah. But if you can advance the retrograde wire with a more stiff wire or any other wire, if you can advance it, I think you can keep on advancing it. But if you face the difficulties, I think knuckle wire technique can be considered. Other than the wire looks like, I'm sorry, the anti-gray wire looks like, the course looks a little bit strange. So, because the CTO is a hybrid procedure, and if retrograde approach is cannot be complete, and the other option is use ADR. Okay. Okay, see, you keep on your procedure. We'll move to case 3.
Okay.
No. Okay. No, we need to still with you.
Okay, thank you.
Oh, retrograde. It seems to be some advancement of the retrograde wire.
Yeah.
So, Dr. Cao, in your clinical practice, in such as RCA, osteo occlusion, and maybe we cannot clearly have the proximal course of the RCA. Will you, in your practice, will you prefer to do the CTA before your CTO intervention to make sure that the course?
Yeah, I think CTA is very helpful for this kind of situation. Yeah, but you know the course of the vessel. Yeah, it can be helpful during the procedure.
Okay. The same question for Shoichi. So in your practice in Kokura Memorial Hospital, is it your routine to do the CTA before CTO intervention or just by case?
Actually, it's routine. So if the patient have a normal renal function, so actually, the CTA is very useful to understand the vessel course. So that's why we always take a CTA so before CTO procedure.
One of our limitation of CTA is it's not reimbursed by the insurance. Therefore, we have fewer chance to use the CTA for all the patients.
Yeah, I understand. Yeah.
But it looks the retrograde looks in the good position.
The wire course of anti-graze looks little, I'm not sure. So, and it is very difficult to keep the duration to the distal wire. So now I changed to stiff wire to make sure anti-gray duration and try to do a kissing wire.
Certainly in this situation, the CTA will be very helpful. But and now anti-gray and retrograde preparation was mandatory in this case. And I think certainly in this situation, CTA will be helpful. But I think in this case, there will be a very large. This is a very large RCA, and there's very large vast bending around the first part towards the second part. And of course, in this situation is very difficult. But I think maybe we can try to do the knuckle from retrograde, because the course now just from the angiogram, this is very difficult to estimate the bending. How large of the bending? What's the vessel course? This is a little bit difficult just from the angiogram. So maybe in this situation, you can do the knuckle wire technique from the retrograde. Of course, during you do the retrograde knuckle, there is a large RV branch. So maybe you can use a stiff wire first to a little bit puncture, and then use a soft wire. Try to do the knuckle from that puncture side.
Okay, retrograde, right? Okay.
But in this view, when you look at the direction, is not so. I think it's a promising position of the proximal. So you should prepare your wire from the retrograde. I suggest you put the wire, anti-gray wire here, and then just start to do the retrograde. Yeah.
Okay. One break. Okay.
What's the retrograde wire?
Conquest 4, because I need to advance a little bit to make my career further.
And it seems that your retrograde carousel have already traveled a long distance. So here is is it the most distal part that the caravel can go?
I still can go a little further. 30 millimeter. I still have 30 millimeter distance. I can push the caravel.
Okay. See, just
Yeah.
your tough case, and so we will leave you and go to the classroom one.
Okay.
Good luck to you. Okay. Can we go to the room one? Huh? Okay. She will stay with you for 2 minutes.
Okay.
Okay. Very tough situation. I think this part is the most difficult part for this case. Okay. It looks like the direction is promising. Okay. This is still conquest.
Yeah.
Okay.
Yeah.
Can you advance more?
See, the anti-gray wire is still black.
No, anti-gray wire is concrete floor.
Okay.
So if possible, maybe we can push the caravel a little bit more to facilitate your visual gray wire support.
Okay, try.
But sometimes it's quite difficult because it has already traveled a long distance.
Yeah. Guiding support is not so great.
Okay, see, continue your hard work, and we can give you to room one. Okay. Okay, Dr. Tsai, can you hear us?
Yeah, I can hear you.
On air now.
Okay. Now we are going to. We already done the IVAS evaluation about the LED proximal calcified plaque. Because
can you introduce your team and introduce your case?
This doctor beside me is Dr. Xu, and she is Dr. Lin, and Dr. Xu will introduce our today's case. And the case slides.
Can you show your case slide? Okay, can you hear me? Hi, can you hear me?
We can see the case slide.
Okay. Hi, I am Dr. Xu. I will present the case. The case is Miss Chen is 74 years old female, and he has underlying disease like coronary artery disease with double vessel disease. She has received PCR in 2017, and this DS has deployed at the second phase. He also had underlying disease like heart failure, PLD, hypertension, type 2 diabetes, dyslipidemia, ESRD, or stroke, and chronic AF. Risk for the CAD for this patient is age, hypertension, type 2 diabetes, and dyslipidemia. She was admitted on April this year with symptoms of chest tightness and dyspnea. So due to a symptom, we arrange a CAG for the patient. Next. The angio show the right coronary artery, IL view, and the LL cranial view. So we can see myostenosis at RCA middle side, and up to 70% stenosis of the PL branch. Next. The IL cranial view and the epicaudal view of the left coronary artery. So we can see the stand of the left second phase distal was pattern, and the AVM formation at the left second phase middle side. And we can see the already long lesion disease, diffuse stenosis, and heavy calcification. The stenosis is up to 90%. Next. So our target today is LAD proximal to distal diffuse long lesion. So we will plan to perform rotational atherectomy for heavy calcification lesion. Okay, this is our case.
So
okay.
Today our case is a patient with DM and hemodialysis, and our target lesion was the LAD proximal to middle diffuse long calcified lesion, and we have angiogram today. And another one. And this is the angiogram today with guiding injection. And we can see the calcified plaque shadow over the bottom and the top of the vessel. And from different angle, we can see the calcified shadow clearly. So I think it's a 330-degree calcified plaque. And we also evaluate the LAD proximal vessel, the IVUS image, because our IVUS image cannot advance to middle to distal portion. So we can only have the proximal segments IVUS image. And we can show the IVUS image to you and have Dr. Huang to comment the image.
Okay, before the IVUS image, we can appreciate that this patient is a very high-risk patient with end-stage renal disease and chronic atrial fibrillation and all stroke and POD, a very diffuse vascular atherosclerosis, high-risk patient. So I think from the angiogram, there look like the circumferential calcium distribute around the vessel. And I think it's very clear that the target lesion is the LAD middle part. So I would like to ask Dr. Lin for the strategy of this patient.
Oh, well, before everything, the first question comes to my mind is what are you going to manage the patient medically? I mean that it's a end-stage renal disease patient under hemodialysis with chronic AFib, hypertension, dyslipidemia, and diabetes, and also all stroke. What are you going to prescribe? The dual antiplatelet, single antiplatelet plus a NOAC or warfarin or anything before you do the intervention? So that's the first question comes to my mind regarding the before the intervention. And of course, I think that it's a quite difficult situation to decide our PCI strategy, but in such a high-risk patient, personally, I would like to know that the LAD is worth to intervene or not. So this is the heart failure patients, and I would like to know, is there any viable tissue in the LAD territory that of course we do the intervention, especially for such a high-risk patient? And also for the heart failure, is there any benefit for us to take such a great risk and improve the patient's heart failure symptoms?
Yes, Dr. Lee raised two very important questions. But actually, this patient suffers from, I think, actually unstable in general. He frequently complained of chest pain before the intervention. And actually, he was admitted due to the management of the POD. Management of the DM foot. Because the surgeon would like to do the surgery for his DM foot. So before the operation, and the patient frequently complained of chest pain. So of course we and the family have a struggling before do the PCI. So actually the intervention has postponed maybe for 1 or 2 weeks. But the surgeon is still concerned about the surgical risk. So I think we have to fix the middle LAD. Because we have do intervention for the circumflex maybe 3 years ago. The 3 years ago angiogram, the LAD middle part is relatively disease-free. And now I think there is disease-free progression. So maybe the middle part have to fix. So what about the medication? Medication, yeah. We use aspirin plus the Coumadin before the intervention. And of course, he suffered from after he complained of the chest pain, we use the Dept plus the warfarin. Okay, yeah.
So will you consider use a clopidogrel in replace of the aspirin? Clopidogrel plus warfarin. Yeah, what's this formula?
Maybe if we put the stent, we will try the 3 combined. For a short period of time, 2 weeks or 1 month, and then we will use the Pravis plus warfarin. Yeah.
Yeah, but because according to the previous study, atrial fibrillation with PCI or ACS intervention, and after the triple therapy, they usually recommended to use the NOAC. Of course, this patient cannot use NOAC. Have to use the warfarin and plus the clopidogrel, I mean a P2Y12 inhibitor, instead of the aspirin.
Sure, you know the insurance coverage. Maybe you have to fulfill the insurance criteria. Can we see the IVAS finding? Dr. Tsai, Dr. Huang.
Okay.
The IVAS cannot pass the lesion, right? So we can only check the protocol part.
Because the lesion is so tight, so the operator cannot advance the IVAS catheter into distal vessel. So the operator, the Dr. Chai, put the 2 wire. One is in circ, another is to LAD. So we from the LAD middle. We can see the lesion pattern is the concentric calcification, and the diameter is about 3.0, about 3.0. So maybe we need to see the another IVAS pullback to see the tight lesion, the lesion pattern. So. Okay.
And Shoichi, in your Kokula style rotablations, so in this case, that since that the IVAS catheter cannot pass the lesions, will you choose first rotaber as 1.25 or 1.5? For this case.
Thank you, Chairman. So, honestly, it is difficult to see the angiogram, but maybe in this case, I start with 1.5. However, this patient has a low LVEF, ejection fraction. So considering the patient characteristics, maybe I start with 1.25, the minimum valve size. So because there is a high risk for the low temperature related complication, such as the slow flow or something. Okay, so the key point of this case is to prevent the complication related to rotablators. That's why if I'm operators, I start with the 1.25 bar. Yeah.
With this from the IVUS, the segment we can see from the IVUS, I think the vessel diameter look fine, and there's not so much disease except the part very close to the lesion. There's some eccentric plaque. Also from the angiogram, we can see the disease length is not very long, and I think the plaque burden is considered to be acceptable. So, and the luminous vessel size is not very small. So I would start with 1.5 millimeter burr, and then because there are at least 2 burrs should be used in this case. So maybe 1.5 or 1.75 or 1.5 plus 2 millimeter burr.
Which means 1.5 plus 2 millimeter. 1.5.
1.5 and then followed by 1.75 or 2.
Oh, okay.
2, yeah.
Maybe need 2 burrs. Yeah.
I think the 2 burrs is necessary, and yes, it depending of the lesion in the middle to distal area. So I will start with 1.25.
He chose the 1.5. I think
that's right.
Another comment.
Your strategy.
My strategy would be to perform the plaque debarking at the first time, because his middle segment may be around 2.5. The vessel diameter may be 2.5 millimeters. So the plaque debarking may require at least 1.5 to achieve our target. And then after 1.5 rotablator, we will consider evaluate the LAD proximal segment by IVUS again to decide whether we should upsize to 1.75 or 2.0 rotablator. It's my strategy.
So now you are using the floppy rota wire or the
rota floppy wire, because we cannot evaluate the middle segment by IVUS clearly. The guide wire bias we cannot evaluate by the IVUS, so we choose the rota floppy guide wire for safety.
Actually, you can look at the guide wire if the guide wire very close to the calcification or not. And I think the proper way is the guide wire can be very close to the calcification, and that is the most effective way to ablate the calcium. And you are using the Rota Pro or conventional Rota device?
Today we choose the Rota Pro.
Okay.
And answering echo to the Dr. Lin's question about triple therapy or double therapy. My question would be, recently the AFib patient in hemodialysis patient with chronic AFib, the NOAC seems to have no benefit for stroke prevention. So maybe the anticoagulation therapy, even in warfarin, in hemodialysis patients. So in Dr. Lin's clinical practice, would you use stroke anticoagulation therapy routinely for hemodialysis patient with chronic AFib?
So in your daily practice, do you stop the warfarin before the PCI? Or if the patient can continue the warfarin? What is your practice?
Because this patient, we do the CH from the femoral approach.
Yeah.
You know, so we stop the warfarin for 2 days. Yeah, but if we do the radio approach, maybe I think stop the drug is not necessary.
Yeah, normally I stop all the anticoagulant 2 days before the admission. Yeah, because I have still a little bit concerned if the patient is undergoing the surgery and there's still a risk.
The shift to the heparin or no molecular weight heparin, right? Yes. So Ian, what's the size of this bird? 1.25, right?
1.5.
Oh, 1.5, okay.
And as you can see, my bird already passed through the LED middle critical segment. So I will polish 2 more rounds and consider evaluate the vessel by IVUS again. On speed.
So what's your initial speed for the rotor?
1,600,000. 106,000. Sorry.
160, right?
160, yeah. 我知道，哎。
Any BP drop of the heavy blocker during your rotablatation?
The hemodynamics are stable and no bradycardia or long pause during our rotablation. 我们等下转到14万了。好，转一下。
So usually what's your strategy to perform the rotablation? I mean, low speed or high speed? So what's your recommendation?
Under Dr. Lu's guidance, we always use we will start from the high speed to passage the lesion, and down speed our rota to polish the vessel. It's our strategy.
So Joyce, in coagulants, are you use the low speed to polish the lesion after you pass the lesion or not?
Sometimes. So actually, our initial speed is 160 or 180. So however, when the patient has a low ejection fraction, so we start with low speed. So 160 or 140. So it depends on the patient characteristics.
So after you pass the bird, will you just try to use the low speed to have the bird BIOS to get more debugging effect or not?
It depends on the doctor's preference. So actually, sometimes to perform the kind of the procedure, the high speed first, and then try the low speed to get a larger lumen. So as you mentioned, not always.
So Dr. Tsai, now you are going to check the IVUS, right?
Yeah, we are using the Mamba Flex to facilitate our guide wire exchange. After we exchange to the workhorse wire, we will evaluate the IVUS again. Or Dr. Lin, you suggest that we evaluate the IVUS with the rota floppy wire?
Well, it depends sometimes because you know, just in our first case, we just mentioned that the rota wire is quite fragile. So if you do the IVUS over the rota wire, of course, it's quite convenient that if you are going to do the larger bird after IVUS evaluations, but you have to be careful that you should not damage the rotor wire.
Totally agree, because the rotor wire is very fragile, and we tried to evaluate the OCT from the rotor wire once, and the rotor wire just kink during while we advance our OCT catheter. So this time we will use the cyan blue as our workhorse wire to evaluate the segment after rotor.
In Kokula, so in your practice that after the first bird passage, now we have to check the IVUS to decide the future, maybe we should upsize the bird. So will you routinely use the IVUS over the rotor wire, or you exchange back to the workhorse wire to do the IVUS? If you have to upsize, you exchange the workhorse wire back to rotor again and do the rotor.
Yeah, thank you. So actually, over the rotor wires, we don't change the normal wire. So just after the rotor bladers. So of course, sometimes we cannot the IVUS catheter even after rotor beta. If so we change to the normal wire, or we upsize the rotor bar. Yeah, this is my style.
Thank you. So it seems that the flow of LED is quite okay. So now it's time for the IVUS. It seems that the rotor is quite effective to debug. Now your IVUS is quite easy to pass through the tight lesion and deliver it to the distal.
Stop 一下，然后开始，可以录了。So we are in the LED distal segment, and in distal segment still have heavy plaque burden. And we can, please, Dr. Huang, please.
Okay, because the wire go back from the LED distal, we can see the LED distal, the lesion type is the concentric classification, and from here we can see maybe the artifact and the classification, concentric classification, and diameter is maybe I searched around 2.5 millimeter. The so tight lesion, the plaque burden is so large, so you can see. Maybe we search from the lesion. We suggest maybe we can increase the rotor burr size to the lesion. So from the side, we see the classification will into the layman, near layman, already also into the near layman. So the long lesion, diffuse long lesion with classification, we suggest maybe we can increase the burr size to debugging the lesion. Thank you.
So tell us, have you done the angiogram after the rotor ablation?
Not yet, because we have tested the flow is okay. So we now evaluate the vessel directly by the IVUS. And now the IVUS image, can you see the IVUS image?
Yes, we can see it, yeah.
And from the tactile feedback and the IVUS image, I think the 1.5 rotablator, the effect of debarking is suboptimal. So the question is, what's the next size of our rotabird?
Can you shoot the angiographic?
Okay.
And then you can decide.
Okay. 好，停了。And what's any suggestion?
From the IVUS image, if in my daily practice, I will try to balloon first. Yeah, because the calcium is not all the way 360 degree. Some part is 180, some part is fine. So probably, and the calcium thickening. But of course, IVUS cannot see the full calcium. But from the calcium thickening from the IVUS, I think there's a chance to dilate the vessel. So if I'm the operator, I would try the balloon first. But if you ask me to recommend the second bird, and I would recommend 1.75. Yeah.
Well, in my view, that the angiographically that the calcium is not so heavy. So of course, by the IVUS is very, very sensitive for the calcium. So it always look terrible by the IVUS. But angiographically, I don't think it's quite so terrible. So maybe I totally agree with the Dr. Cao that personally I will now do the NC balloon predilatation and try to evaluate the expansion of the NC balloon. If not, I will try to upsize the bird. But if okay, so I will do the sequential predilatation and standing.
Yeah, I agree too.
Okay, then it's a good thing for me not to not to use another bird to perform the plaque debarking. But the next question will be, because the disease was extending from the LAD distal all the way into LAD ostium. So to treat the LAD osteal lesion, should we perform the osteal standing or Lemon to LAD provisional standing? And I need some.
Well, I think it's a hemodialysis patients. So the clinical outcome of this kind of patient is very, very poor. No matter how good you do for the acute result, even you do 100% perfect, the patient will come back for the instant restenosis maybe within 3 months or 6 months. So that they always say the enemy of good is perfect. So I think I will not all the way stand back to the LAD ostium, even back to the left man. I will just stand at the proximal segment of LAD.
So what's the cross-section area of the proximal LAD from the IVUS finding? Especially the
this is LED Austin, and
yes.
It looks terrible by IVUS, but I think the lumen is quite huge. So in this place, I will skip it. Yeah, just leave it. It's big enough.
Yeah,
it's big enough.
Okay.
So from the IVUS finding, we can the area of the LED Austin is about 12.5 milli square. So maybe we agree the Dr. Lin, we maybe don't deploy stand here.
To provide a disease segment, and after the NC balloon inflation, we will evaluate the IVUS again to see the calcified plaque was cracked or not.
So what's the balloon size that you are going to use?
We choose the 3O.
3O NC balloon, right?
Yeah, 3O NC balloon. Maybe it's a little bit too large for the middle to distal segment. Yeah. Okay.
But it seems to me that the 3O is quite adequate.
It's quite adequate. Thank you.
Yes. By the angel, I think the distal landing should be at least 3O.
Okay. Thank you, Dr. Lee. 这里来12。
Can we see the angiogram? Can you move the angiogram to the big screen?
Okay.
So the balloon can be dilated quite nicely.
Yeah, it can fully expansion.
The most calcified part is at the plasma. Yeah, it looks good.
Yeah.
So what's your pressure?
12.
Only 12.
Yeah, nominal pressure.
Yes, it's good. It's good. Only 12 can fully expand your 3O NC balloon. So it's a good sign.
It's a good sign. Okay, thank you. And now here. In the proximal segment, since the balloon can be fully dilated too. Photo view.
I think you can skip this part of dilatation because if you're not going to stain this part,
okay,
you can just leave it.
Just leave it alone. Okay, thank you. We are advancing the IVUS catheter. 刘大哥 ，IVUS 哦。
我已经帮他，就是可能。
OK，
对，我帮他传带给那没办法。
OK，record。需要你的脖子。对。
The IVUS is pulled back from the AD distal, Now, after band dilatation, maybe use the 12 ATM to fully band dilatation. So you can see the crack of the calcification, and the vessel diameter is about 2.5. Then we can see the asymmetry the vessel size, and maybe from here. But the LED proximal to LED awesome, because we don't want to deploy stencil this side. We can see anything from here. Austin. 对对。
Okay. In real time again. Real time.
So we real time again to check the lesion size.
And this is a real-time image of IVUS, and we already in the LED very distal segment. And I don't know where is the proper distal landing zone. Could you give me some opinion? Some advice?
So
very distal.
There's some dissection, right?
Yeah, there's some dissection over here.
Maybe you should cover the older dissection. Yeah.
Okay. But until here? Well, it a little bit too long.
So
can you continue to pull back?
Okay. And there is the manual pullback.
Yeah. I think the segment you choose, I think it's fine.
It's fine. Okay. Yeah. Thank you, Dr. Cao.
What's the location from angiography?
刚才有说嘛。
The location is the LED distal from
very distal segment.
Very distal.
Very distal.
Yeah, I think so.
It's very distal.
I think it's too distal.
Yes.
Yes. So
from the angiography is too distal.
Yeah.
You are going to cover everything. You always put 248 stent. It's too distal.
Okay, so
maybe we could choose another distal landing zone.
Okay.
Maybe around this place, is it?
Here?
I mean for the angel.
Previous angel.
Maybe here should be okay.
Should be okay. Okay, let me.
Now the lumen is almost 3.0, right?
Here?
I think.
Angel graph seems fine.
Of course, this distal landing zone is not perfect, but I think it's quite adequate for.
Agree. Yeah.
So can you show us the IVUS finding at this point?
Here is the IVUS image over this segment. So maybe, and what will be the stent size of this segment from if we choose a distal vessel sizing?
Well, I would say 3.0.
Yes.
3.0. Okay. Thank you.
But deploy at low pressure.
Okay, understand.
Okay. Your low pressure mean the mean nominal pressure.
Yes, usually 12 or just 10 or 12, depending on the inflation.
Okay. But the IVUS shows the distal vessel. Our landing zone, distal landing zone is about 2.5. But why do you choose the 3.0 stent?
Because from EM to EM is
okay.
So I think 3.0 should be fine. Yeah.
And for angiography, not so small.
And the next question will be, where is our proximal landing zone if we are not going to touch the LED ostium? And this is the proximal segment image of IVUS image, and will be acceptable if we choose proximal landing zone is here.
Yeah. So where is the location at the angiography?
Angiography here. And can you see the angio? It's real time. IVUS and angio is real time.
Yeah, yeah.
Oh,
so the lens will be more than 60, right?
Yeah, it's about 62 to 64 around. So we may need 2 stents. And the proximal stent, what will be the suggested size about proximal stent?
So if I would like to have 3048 for the distal, and then another 35 for proximal, and the lens will be decided after the first stent deployment.
Okay, totally agree. 那3.048的 signature.
If we want to use a 2-stent, maybe the first one, we don't need to use the longest one. Maybe 38 plus another 38.
Well, if we can deliver the 48 stent, I think it's okay. It's okay. It's no matter 38 or 48, it's both fine for me.
Okay.
Except that there is a major branch just at proximally. So if you don't like to overlap 2 stents at the major branch, if not, I think either one should be fine.
这里选多少？哦，是吗？
Okay, thank you. Okay. So here is our 3048 synergy. Yeah, 我们上一张来，上一张，在上，差不多在这里嘛，distal landing zone 啊。
I think just at the septal branch, maybe a little bit distal to the septal branch for the proximal stent edge.
Okay.
So can we pull back the stent and just use only 1 stent?
Probably you can just
use 1 stent can cover.
To cover all?
Yeah.
Okay.
Yes,
Okay.
I think so. You can pull back a little bit.
Okay. Okay. I think it's the best condition.
Just only use 1 stent.
Just use 1 stent.
Yes.
Here? Is that possible?
Maybe a little bit distal.
Yeah.
Just proximally to the septal.
Proximally
to proxima.
To proximal.
Now it's 2 proxima. You can advance more distally.
Okay, test that. Okay, here.
Test, please.
No, 浓一点，这个都太淡了。Pure.
It's fine, but if can slightly distal.
Okay. OK， 好，来，对，没关系，我们照一张啊，看清楚。Here， 这个帮我拍一下机。Does this portion is fine? Or standing here?
Not fine.
Well, of course, at your proximal is okay, but distal maybe just land at a relative narrow part.
Narrow part, so we have to advance more.
I think it's okay. I think it's okay. If needed, we can implant the second stent. Okay. So I think this location is okay.
I advance a little bit more, so We can see the angel where it is acceptable. Oh, it's definitely not okay to.
Yes. So
yeah.
I think the original one is okay.
Original one is okay. Okay.
You just care the proximal side, don't care the distal side. Okay?
Yes, totally.
I think, yeah.
Totally agree.
Okay.
Maybe a little bit more proximal.
Here? Is here acceptable?
Yes, it's okay.
It's okay.
Yes.
Okay.
Okay.
Thank you. Okay, inflation
Yeah, it's okay.
Standing 6个8。10。8。10。12。Okay, 好。
So it's quite hard at the proximal segment.
Yeah. 12。用刚刚3.0就好了。好。
It seems that the stand expand very well.
Yeah, it's fully expanded. So I will use the 3O non-compressed balloon to post-dilate our stand. And after the post-dilatation, we will evaluate the IVUS again to see whether we need to upsize our NC balloon.
So Eden, please go ahead and your work, and we will move to the room 2 to see how about the result of the CTO intervention.
Thank you, Professor Xue.
So please move to the room 2. Yeah.
Yes.
Zhenmin, we are back.
Yes. Okay. I just take over the Dr. Deng for the rest
yes,
of
the
the
course,
intervention.
it is a very tough case.
Very tough. I think there is a large bending for the first part and second part.
Yes.
RCA. So I try to retrograde approach first. Use Conquest Pro 12, and then I try a little bit for the knuckle, but because there is some manipulation before, so actually, and then the support is not so good. So knuckle Y cannot advance further. We use a Sion break for knuckle Y. And so I shift back to the UV3. I guess that the UV3 may be a little bit more controllable. So I use a UV3 and try to touch every direction, and then suddenly they give the resistance give up, and the Y can jump backward like this. So I think this the distal Y maybe I think in the wrong direction. So I shift back to the anti-gray Y again next. And this time I use Conquest Pro and create a large bending, maybe 5 to 6 millimeter next, and very large bending, and then next. And you can see that I try to advance my Conquest wire slowly, and try to advance more backward, more upward, downward. You can see the direction of the Conquest wire, and now retrograde wire is now is where we are. The retrograde wire is UV3, and the anti-gray wire is the Conquest Pro 12, and it looks like the both wire jump together, and maybe in the close part of the vessel. So, but we have a large resistance here.
Yeah, I remember this patient received a CTA study, right? No? Okay. So that's a very big angle, very big curve, yeah. So now integrate Y is Conquest Pro and the retrograde Y is a UB3, right?
Yeah.
Yes.
So, because my UV3 cannot move forward, so maybe I will shift back to the conquest, another conquest from retrograde. Try to approach my integrate Y.
Yeah. But the first time the retrograde Conquest Pro went into the subintima.
Maybe.
Yeah, okay. So the anti-gray support is still not so good. Yeah. Oh no. Yeah, promising.
Yeah, it looks promising.
Yeah.
Well, you can see that the resistance is very large and the support is
advance the retrograde microcatheter?
Yeah. We can go here, but no more. And
okay. Not so easy.
Yeah.
How about the IO view?
IO sensor. This is cranial, and we'll do the IO.
Okay, yeah. Very close. Very, very close, almost touch.
Yeah. Both cannot go. Maybe we should have to try another Conquest Pro 12. That's it.
You mean retrograde?
Yeah, retrograde.
Okay. So tell me, this is the previous route, right?
Yeah, but
do you think the wire went into the previous subintima space?
You mean that the retrograde or integrate?
Yes, retrograde wire.
Retrograde. You can go two directions. You can see first that you can move upward, but I think that's maybe subintima space.
Yes.
So a little bit rightward, maybe the more pervasive, but I cannot sure that is subintima or intrapregnant. Yes.
Okay. Okay. So we will go to the room 3, case 3, because it may be finished the case already. We will be back very soon, okay? So, 再转到
Finish the 3 or non-compressible.
We are back.
Oh,
Yeah.
okay, Dr. Xie. And we already finished the 3O non-compliance balloon post-dilatation over the standing segment. And we also evaluate the effect of post-dilatation by IVUS. And Dr. Huang, please. Could you see the IVUS image?
Okay.
Yes.
We can see that after the deploy stand and use the NC balloon dilatation, we see the IVUS from the stand distal to stand proximal. Into the, I see the symmetry expansion, the stand symmetry expansion here, and withdraw. I can see maybe due to the classification lesion type. So I think the stand not expansion, symmetry expansion. Here I think so tight, so we can do another NC high pressure balloon dilatation. And from here, this side not stand, so it's my comment from here.
Okay, thank you, Dr. Huang. And this is the angel after we evaluate the IVUS image. And as Dr. Huang suggested, we are considering using 3.5 non-compliance balloon to post-dilate the proximal segment of the stent. Is there any suggestion, or just leave this alone? It's acceptable result.
How about the minimal stand area?
Minimal stand area.
Let me check. You mean here?
Yes. Maybe here.
Yeah.
Yes.
It's an oval shape of the stand.
It's okay for oval shape, but we are considering the area.
Yeah.
So in this area, did you use the 3O NC balloon to do the post-dilatation?
Yes, we already finished it, and
so,
with
so
high bar.
I said 3.5. It's okay. We can try it.
Try 3.5. Okay.
Yes.
3.5 NC emerge.
So what do you mean the high pressure? How high?
20. Is that enough?
Well, sometimes we use 24, 26, 28.
24, 26. Okay.
Sometimes that depends on
okay.
what kind of NC balloon.
NC emerge. We use the NC emerge and inflate it over 20. I saw it's already high bar, high pressure, and I will try higher next time. 我怕 emerge 摇坏了，如果是 RQ4 才 maybe 可以。
So, Shoichi, what's your recommendation for this IVUS? Do you think it's big enough? So we should go for the 3.0 higher pressure or upsize to the bigger balloon?
So, thank you, Jabin. Actually, this situation is some high risk for corneal perforation when performing post-dilatation. So if I'm an operator, I stop the procedure at this timing. So actually, it's difficult to get larger lumen even if with the E3O balloon at high pressure. So this IVUS is a typical IVUS image for high risk IVUS image for coronary perforation. So,
but because the other side of vessel wall is very thin, right? Like a clear stand.
And so could you show us could you show us the previous point? IVUS image, not distal.
这里先12个吧。笔打开，我两边照上一下。
So what is the balloon size?
3.5, and we inflate it with nominal pressure first, and now we are considering inflate it with more high bar. Okay, 20. 24. Okay. Okay, stand 再一次，再一次还有。And can you see the clear stand image?
Very clear, yeah.
Very clear. And since the stand is limited by the calcified plaque, so the expansion is not very symmetric.
Yeah. But if the indentation need to be direct, I would choose a 8 millimeter balloon.
8 millimeter balloon.
Yeah, 8 millimeter. And the expansion force can be more focused. Yeah.
Understand. Thank you. Oh, quite lucky, right? No perforation. No perforation. Quite lucky. I was.
The plasma vessel is big enough. It's quite big. Yeah.
Okay.
Especially this calcified region, and you perform the dilatation within the stent. I think it's relatively safe.
Thank you. Because I'm worried about the vessel wall. Another side was relatively thin. So I'm afraid about even after standing, the vessel will perforate it after high bar NC balloon post dilatation. And now we are checking the IVUS image again inside the stent. 好，那个刘大哥 ，IVUS。哦，好，需要谢谢。And our IVUS catheter is already inside the middle segment of our stent. And this portion, we did not use the 3.5 non-compressed balloon to post-dilate it because we think it's already acceptable result. And from this part, we use the 3.5 non-compressed balloon to post-dilate it with high bar 24. And maybe the minimal stent area becomes better. That is possible. 好听啊！
你就拉那一段对不对
And we can 那个
你就拉那一段嘛，对不对？
对对，我们只拉那一段，刚修的那一段啊，学长请。那个 ISO 给我。
So after the bigger balloon expansion, I check the area, the stent, middle stent. So I think the result is more better than PVR balloon dilatation. So
好 ，OK， 还有吗？有一点少。
I think IVUS is okay.
哎呀，多一点。pure 的了，这都 bubble 了，再给我一点。要跟他省，而且我们要缝脚，我想缝脚，对，把脚缝起来。啊？蒙皮啊，不，那开，等下照一张看一下好了。蒙皮啊。
I think we can accept the result. Yeah.
Okay, then, then we will check the final angiogram. 来 ，Koto 加 Spider。
Very nice.
And it's the caudal view and spider view of the final angiogram, and this one is the cranial view, IO cranial, and the true lateral view of the final angiogram. So
yeah, very good result.
Can we stop here?
Yes, you can.
Yes.
Congratulations.
Thank you.
Good job. Yeah.
Thank you very much.
Very
and
good.
We will finish.
Thank you very much for your demonstration.
Thank you very much.
So we will move to the room 2 to see how about the result of the CTO PCI. Case 2.
Okay.
We are back.
Okay. When you leave us, this is maybe the next scene we have just take. This is the integrate looks like very close. So now the retrograde wire is UV3. So, but there are great resistance. Both wire cannot move. So I shift to the Conquest Pro 12. And the next. And then I try every direction and I try to cross the integrate wire, but the retrograde wire still cannot move. So finally I shift to my integrate wire, and integrate wire during the wire preparation, wire manipulation, I try to advance my microcaster to increase the support. This is microcaster is a Bamba microcaster from the Boston Scientific. And so I think during the manipulation, I put back a little bit for the Conquest Pro and find that actually the vessel curve return to I think more reliable course. So previous. So I think that this may be due to too much manipulation of the wire, especially the Conquest. So maybe there are some weak point that during the manipulation, the wire can go out to the vessel or cause some tearing of the vessel. So when I put back my integrate wire, looks like the most wire may be more close to each other. So this is where we are.
Okay. So you think that actually there is no small curvature of the segment 2, right?
Yeah, because this vessel may be very large, maybe at least 3.5 or 4 millimeter, or even sometimes 4.5 or 5 millimeter large vessel. So there are large space in the vessel, so your wire can go to show that very large exchange curve. But maybe this is a more acceptable curve like this.
So now both the integrate and the retrograde wire are Conquest Pro 12, right?
Yeah. Both wire Conquest Pro 12. But my integrate wire still cannot move again, and now my retrograde wire can go back.
Because the integrate support is quite bad.
Yeah. Cranial.
Yeah.
Maybe we can do the reverse cut here.
Okay, because the time is up, so I have to make a brief closing remark for this meeting. And first, I would like to express my congratulations thanks to the Taipei Veteran General Hospital and the Boston company to organize this very good meeting. And in this meeting, we have 3 cases of the lab demonstration, including long lesion, calcified lesion, and the CTO case. And all the 3 cases are complex case and complex patients. And we also have 2 special lectures regarding the IVUS for the calcified lesion and the CTO lesion, especially which were presented by our Japanese expert, Dr. Hongye and Dr. Kuramitsu. So in this meeting, also lab demonstration case and also a lecture show us that IVUS is very important to when we perform the complex PCI. It can give us the information of the vessel diameter and the lesion length and the plaque characteristic and the post-standing evaluation. So it can help us to have a very good strategy making and procedure monitor. And I think in the future, we should have to use the IVUS guided PCI more and more. And at last, I would like to, thanks to all our Japanese friends and all the moderators, panelists, and operators, and the audience to join this very great meeting. And I hope that we can have a face-to-face meeting very soon in the future. Thank you very much. Thank you. Thank you very much for your joining. Thank you.